Chance of it falling. Yes, nice one.
This young stud. So you're all up ready for
Alright guys, our next speaker is Dr. Creatine. He's a professor of clinical exercise physiology down at University of Pittsburgh. His research interests include exercise management for hypertension, as well as carbon-fitted or fiber-fitted running shoes or something. Sorry.
That would be appropriate, yeah, that would be perfect. Yeah.
Dr. Creatine.
Thank you so much for that introduction, and also thank you all for spending your Saturday here with us and a number of other people looking at some really cool things and having some really fun topics to discuss. So I'm grateful that you're here. Thank you for your time and your energy, and hopefully I present you with a topic that maybe is something you haven't thought about or haven't considered in depth, but it's probably something you've heard of in some of your classes, but our application is a bit unique, and so that's what I'm going to talk about today. So as far as the talk goes, my presentation is titled Enhancing the Exercise Physiologist's Toolkit, Prevention and Management of Hypertension. Following the introduction, I am an assistant professor of clinical exercise physiology at the University of Pittsburgh. Prior to my appointment at Pittsburgh 2 years ago, I spent 4 years in the exercise science program at Slippery Rock University, so just down the street, in their exercise science program, studying some similar things with some of their faculty, and I brought some of that work with me most recently down to Pitt. Now, I know with weekends and classes, you're all very busy and you're learning a lot in your classes. I'm not going to spend a ton of time talking about the complexities of blood pressure and how it's regulated, but nonetheless, I think it's important that we acknowledge and appreciate how complicated it actually is. So in many of your classes, whether that be in human physiology or in anatomy and physiology or even in your exercise physiology courses, we understand that blood pressure is regulated through a number of mechanisms, plenty of them. Now, the two big ones that we're most concerned with regarding blood pressure is going to be cardiac output, which we know is made up of two specific variables. So we've got heart rate and stroke volume, both of which can change, and peripheral resistance. Now, across the board, and it's much more complicated than this, if there is some level of dysregulation or dysfunction or disease associated with one of these regulatory mechanisms, the result is hypertension. And now it's not an overnight process. Sometimes it's going to be taking years, decades, an entire lifespan before you start to see the effects, the ill effects of some of these things associated with that dysregulation. In some cases, it happens quicker. So if someone has renal disease, or if someone is actually predisposed to the condition or has another secondary cause, that is more problematic. But the problem persists regardless, and at some point, some person in your life is probably going to have hypertension or currently has it. And so that's what we're going to talk a little bit about today in terms of how do we address this growing problem and how do we meet the needs with where they are. So in terms of the background, let's just kind of set the stage for this problem. And we know that it's significant, okay? So here are just a few statistics for you. Everyone likes to start off with, this is how bad the problem is, this is how it's getting worse, how are we addressing it, and that's what I'm going to talk about today. So hypertension, or blood pressure in itself, is one of the most modifiable risk factors out there. You can change it by modifying things like your diet, your physical activity levels, salt intake, taking medications. All of those things can contribute to an improved blood pressure control. But that dysregulation in normal homeostatic control does increase your likelihood for hypertension. Also happens to be a strong risk factor for heart disease, so coronary artery disease or coronary vascular disease, however you like to go by. So it's one of those strong risk factors. 1.1 billion people worldwide, and 46% of adults in the US exceed those hypertension thresholds. That's a lot. So nearly half the population, the adult population, is having an issue with managing their blood pressure. And the worst part of that is that a lot of those people don't even know that it's a problem. Because hypertension, as you've probably heard it called, is a silent killer. We're not aware that that is a problem until someone has a significant event, or they're going and actually meeting with their primary care provider and having a conversation about their blood pressure problems. But as a first-line strategy, there's a big paper that came out just a couple years ago where they said, hey, we know exercise is effective. But if I were to ask anyone in this room, and I said, what type of exercise do you think is most effective for managing blood pressure, what would you say? And for those in the room, raise your hand, you give me an answer, you're not wrong. But what would you say is the most effective type of exercise to manage your BP?
Aerobic exercise?
Aerobic exercise, yeah, that's a great example. I would probably agree with you to a point. What about something else?
Animal flow.
Animal flow, yeah. Yeah, there we go. We got animal flow over here lowering BP. Okay. Not wrong either because it's moderate to vigorous physical activity.
Yes.
Right? Yes. Those that have participated in those studies with Dr. Buxton, I know I'm sure you've had that experience yourself of moderate to vigorous physical activity. What else? What did you go to a demonstration for today earlier?
Weight training.
Weight training, resistance training, yeah. And actually one of the biggest things you can do is a combination of those things as well. So aerobic and resistance. When I asked my question, did it dawn on any of you, the first thing that you would think about was isometric hand grip exercise? Some of you might have said, oh, I saw an article in the BJSM, or it was this big thing on the New York Times. Well, it's growing in popularity, but yeah, it's not the first thing that we're drawn to. That's what I'm going to talk about today. Now, we also have medication, but the big problem with medication is that adherence to those meds does decrease, so we have less than 50% success rate within a year of that prescription, okay? So what we can do is we have a problem, we have an intervention, so it can be a lifestyle modification, it can be a medication. We know that there are other risk factors that contribute to these things, but we can address them in some measurable way with aerobic and resistance exercise. In adding that, we hope to balance the equation. Nonetheless, these are numbers that you should be familiar with. These are ones that you've probably come across, whether it be you or your parents. But these are the most recent thresholds. So according to a 2017 update, we got rid of pre-hypertension. We now have normal, elevated, stage 1, stage 2, and then a hypertensive crisis. Now, what I also want to draw your attention to in this, which I think is so important, is that we get stuck on this 120/80, that is considered normal. Well, according to the guidelines, it's actually less than that that's considered normal. And so it's not, in fact, that 120 threshold that we're so worried about anymore. It's actually that we want to be below that, okay? So how do we get there, right? How do we address this problem? Now, I have one other question for those in the room, and this can just be a general raise of the hand. For those in the room, have you had your blood pressure measured recently? Hands up. Hands up if you had your blood pressure measured in one arm. Confident. Go ahead and throw your hands up so I can see better. There we go. Did you have your blood pressure measured in both arms? 1, 2 people in the room. Interestingly, and this is just a side note for you, I'm not going to talk about this much today, but there is such thing as an inter-arm difference in blood pressure, which we tend to overlook. So we may be missing someone who has a higher blood pressure in one arm versus the other. In some cases, a 10 millimeter difference between arms is actually more problematic than having a smaller difference between arms. So for those that go to the doctor, I encourage you, have your physician measure that blood pressure in both arms, because you don't want to be missing out on wherever that high blood pressure is. So, here's some guidelines for you. Everyone loves guidelines. We love the ACSM guidelines book. We know that this is based in a lot of data, epidemiological data, to support what lowers BP and how. So we did have a couple of those modalities that were outlined for us. So we have aerobic, we have dynamic resistance, and we also have combined aerobic and resistance training. Now, in the next couple of slides, I want to draw your attention to the right-hand side of these tables. On the right-hand side, I have for you the average effect on BP. So you have your systolic blood pressure and your diastolic blood pressure. And in that, according to the report, whether that be a meta-analysis or a systematic review or a pairwise analysis, these are the ranges that we see a reduction in BP in using each of these modalities. So again, to draw your attention, -4 and -2 to 3, -2 to 4, -3, -3 to 6, and -2 to 3. Not bad. It's a robust response, okay? Now, in addition to other lifestyle interventions, it can probably have a more measurable effect as well. But a problem persists. Most Americans don't meet the guidelines. Biggest problem? Time. We were just talking about this at lunch. The argument is time. I have to invest all this time. I have to go out and get sweaty. I have to go to a gym where I might be uncomfortable. I have to put myself in a vulnerable space just to lower my blood pressure. Not to mention, blood pressure is really probably not something they're thinking about, okay? Which again makes the problem that much more difficult to manage. So, cost, boredom, time, but I think another thing, and most critically, is what I've underlined for you here. Most critically is the knowledge of and the means for implementing alternative strategies. So again, I asked you a question. How many of you would think firsthand isometric hand grip training was going to be the thing that comes to mind when you tell someone that they should go and lower their blood pressure? No, you're shaking your head. And about 10 years ago, I probably would have said the same thing. Okay? So you're not in the wrong on that, but I hope to bring to your attention something new and exciting. So when we talk about this, we talk about these alternative strategies, okay? Non-traditional. There was a bunch of papers published in the last 5 years or so that talk about, well, how can we add on to the existing body of literature? How can we make a difference, but not just focus on aerobic resistance? Let's talk about yoga. Let's talk about Pilates. Let's talk about all these other different modalities you can engage in. Let's talk about isometric exercise. But what I also want to talk about is I don't want to replace these other modalities. I want to supplement. We don't talk about supplements. Adding something to make a more measurable effect, okay? Or improve something, the quality, benefit. Isometric training has a role here as a supplement, an adjunct, not a replacement, okay? So I just want to make sure that you remember that today. So what is that? What do I mean by isometric training? What am I getting at with this? So in short, isometric means that there's little to no change in the length of the muscle. Yes, there's going to be micro changes. We might see just a couple of actin myosin heads interacting a little bit, a little shortening, a little lengthening, but ultimately the overt length of the muscle is not changing much. So it's holding a plank, it's holding a squat, it's a wall sit. All right? These are exercises you've probably engaged in your own form of training. But that type of training also, supposedly, according to the data, has a measurable effect on lowering blood pressure when used in the right way. So these are sustained contractions. We typically deploy about 30% of maximal voluntary contraction using a hand grip dynamometer. So everyone remembers stress balls. You probably use the hand grip dynamometers. I'm telling you that you squeeze and you hold at about 30% of your maximal voluntary contraction strength for 2 minutes. That is going to be the longest 2 minutes of your life, I promise. Okay? Now in that, you then relax, you wait a minute, then you hold again for 2. And you relax, you wait a minute, you hold again for 2. You do 4 total contractions, all right? 4 contractions, 1 session, that's 11 minutes total of time spent. 11 minutes of just hand grip exercise. 3 days a week, 33 minutes. What do the guidelines say? 150 to 300 of moderate to vigorous physical activity to make an effect of -3, -2, -4 millimeters of mercury. Okay? So I want you to remember these numbers. Data suggests that we can impact hypertension by doing this type of therapy as a supplement, as an add-on. Okay? Now there is more evidence required, more trials required, and that's something that we're actively working on right now with myself and a number of groups across the world. So what do these protocols look like? Let's continue to set the stage for what those expectations are. You have an isometric hand grip intervention versus a control group. That's our dynamometer. You have a group that doesn't do the activity at all. You do 3 days a week, 30% maximal voluntary contraction. You have a sham group, because of course just doing a do-nothing control doesn't really tell us all that much. So they do 5%, which is well below enough of a threshold to make an impact on any measurable change in BP. We do that for about 12 weeks, 3 months, okay? We then measure some really cool markers: rate pressure product, pulse wave velocity, 24-hour ambulatory blood pressure, and we can also do HRV every 4 weeks. In that, we see these changes where it's the reduction in BP and an improvement in these cardiovascular indices. Again, 33 minutes of activity per week is all that's required, okay? So it's not a lot. It's not a huge amount of time. So you ask, well, what's the data look like? Let's look at it. But let's look at it from a historical perspective first. The first paper that was really published in this area was back in 1992 by Wiley et al. That was an MSSE where they saw reductions in BP over 4 weeks, and the BP went back up as soon as they stopped the activity after 4 weeks went by. That makes sense? That how mentality of use it or lose it. If you stop, it goes back to normal. Yes, okay. Well then, years later in 2016, a similar group did another hand grip intervention and tried to address the sex effect. They looked at males, they looked at females, they looked at pulse wave velocity, but importantly, they also looked at blood pressure. In every one of these studies from 1992 till 2024, we have seen measurable reductions in blood pressure with hand grip, with wall squat, with plank. These are the main activities that we've deployed in some of these studies and see measurable reductions in blood pressure. Most recently, there was a group based out of the UK, a couple of collaborators of mine, that published a paper in 2023 where they did baseline assessments, did the assessments a year later, and blood pressure was still below baseline. After a year of just doing wall squat exercise. Now, with wall squat, you're like, that's not fun. How many of these squats do I have to do? What intensity? How frequently? I have a slide that I'm going to share with you today that does show you the protocols and how to implement them best. And the best part, 15 minutes of your time. I feel like a salesman, but I promise you, the data is there, folks, I promise. So with isometric training and blood pressure, let's look at what that data tells us right now. And again, I want to draw your attention to the right-hand side of this slide. Look at that red box. Look at those numbers. 11, 8, 7, 5. Now, if my memory suits me, which on occasion it does, those are better numbers than what we saw previously. Those numbers are larger. And believe it or not, in some of these studies, it was the only type of training that was used. Hand grip, wall squat, or plank. Okay? So, with that, using these protocols, isometric hand grip, bilateral leg extension, bicep curl, all sessions were great, or all interventions were greater than 2 weeks, 12 to 15 minutes total, 33 minutes a week, 1 to 3 minutes between contractions. And another little tidbit, the better the effect, unilateral, not bilateral. I wonder why. We're trying to figure that out because, okay, mechanisms. What are the mechanisms responsible to contribute to this effect? We'll get into that a little bit. But first, not only are we seeing significant reductions between 4 and 12 weeks, but the longer you do the intervention, the longer the effect also seems to last. We published a paper in 2023 in the Journal of Clinical Exercise Physiology where we did a 12-week intervention, older adults, polypharmacy, which means they were on multiple medications, on average 4 to 5 antihypertensive medications. These individuals also had hypertension that was not managed well, so it was poorly managed. We gave them the hand grip intervention. It was at a senior center. We worked with them on site 3 days a week, doing the exact same protocol I described to you. On average, the reduction in blood pressure across our intervention cohort, 10 millimeters of mercury. Anybody guess what that reduction in BP was after 12 weeks of doing nothing after the intervention was over? Throw a number out there. What do you think the reduction in BP was sustained at? Got 5? Okay. What else? 8? I like 8. Give me one more. 10. About 9. 9 millimeters of mercury still below baseline, 12 weeks after the cessation of training. In older adults who were currently being managed with 4 to 5 medications. So of course we start to wonder, why is this working so well? Will it work in people who are elevated BP? Will it work in those who are not on medications at all? Will it work on older adults, young adults, those with normal blood pressure? In a massive analysis that was published again in 2023 and a massive review that we just submitted for publication in 2024, that holds true. It works with everybody. It doesn't matter where you start, but it does have an impact on blood pressure. Males, females, older adults, young adults, those on meds, those without meds. And this is that paper. And in that paper, they did a pairwise analysis where they brought into it individuals who were sedentary, those who had gone through trials with HIIT training, aerobic training, resistance training, combined training, and the isometric intervention. And in that data, the greatest reduction was in those who did isometric exercise training. And this was in 270 trials of 15,000 participants. But here's the best news. I'm not sitting here saying isometric is the best thing on the planet and that's what you should do to manage your BP. Every one of these activities has been shown to lower blood pressure. It just so happens that the impact isometric has is significant and warrants further investigation, which is why we're studying it. I'm going to talk a little bit about what our current projects look like and what our future data looks like. But according to this analysis, this is probably the one you may have seen in the news, New York Times, MSNBC, BJSM, BBC, they went off on this paper about how exciting the data was, is that isometric is the most effective for lowering BP, and results may help support future guidelines. But we're not quite there yet. So what I want to share with you next is just a snapshot of some of the data that I've collected over the years, and what some of that data looks like to support this larger analysis. On the left-hand side, we assessed limbs, upper body versus lower body. We did bilateral leg extension. We did bilateral bicep curl. Reduction in BP, exactly the same. Oh gosh, well that boggled my brain because I was like, it's a muscle mass independent effect. That seems to complicate matters further, so what do we do now? We worked with older adults with hypertension. That was the group that saw the 10 millimeter reduction in BP. And then in that paper, or this was, I'm sorry, the one in the middle here was actually a home-based study. So we had folks come into the lab, we had them do it at home on their own, and then we also had a control group. The lab-based group and the home group had the same blood pressure reduction. Okay, so that means I can do this effectively by giving it to you, you do it at home on your own. So now I've eliminated the problem of having people have to come to the lab for this, and they can do it on their own at home. And then we also showed that it worked in older adults and that the effect persisted up to 12 weeks after the intervention had stopped. So I addressed all these gaps. I said, okay, there's some direction. Well, where do we go next? And so mechanisms started to make sense. And so in the past, in the present, and in the future, where are we headed with this work? Okay? So we looked at older adults. We looked at those in the compromised cardiovascular system and older adults at a heart hospital. Home-based programming all led to reductions in BP. So the next question was exercise adaptations and mechanisms, as well as how can we hopefully modify the guidelines. Which meant we need to optimize IET for individual prescription to achieve BP reduction in the clinic and in the community, assessing BP bilaterally, because we don't want to forget about our interarm difference, and then using IET as a standard supplement as a part of an antihypertensive therapy. So that was the goal, and that's what I'm working on at Pitt right now, is looking at those next steps. Now, as a part of the mechanisms discussion, we started to explore the impact of that upper body versus lower body to see, are there changes in biomarkers? So we're looking at interleukin-6 for its anti- and pro-inflammatory factors. We looked at VEGF, vascular endothelial growth factor. Are we maximizing collateralization within these vessels? Because if you were to think about it, during an isometric contraction, you're impeding blood flow. And if you impede blood flow, all these factors start to build up. And as I release the contraction, it causes a flood of these factors into the system, which is going to be promotional of all these antihypertensive benefits. That's the logic. That's what we were thinking. So in this group, we had upper body versus lower body. We had, this was over the course of 6 weeks. We took blood samples at baseline, and after 6 weeks, looking at each of these markers. This was a good thing and a bad thing, but the blood data, no change. No difference between upper body versus lower body versus control. But the reduction in BP still persisted. So it's operating through an entirely different mechanism, okay? But I still think that in this, we're enhancing the quality of the vasculature in which we are reducing vascular resistance. For those folks in the room here, you're in an exercise science program. When you exercise, do you not increase the vascularity of your muscles, right? And when you increase roadways, what do we see? A reduction in resistance. So if we're doing this training, and I have these small resistance vessels, which are primarily responsible for affecting BP, I impede blood flow, I release blood flow, factors build up, and then enhance vascularity. That's a question that remains to be answered, but it's something that we're currently exploring. But I still think that the rationale behind this, despite a reduction in blood pressure and currently no change in markers, means that one of two things. We're looking at the wrong markers, or it could be an intensity effect as well, or a timing of the blood draw. So this is just a closer look at what that data looked like for both diastolic on the left and systolic on the right in bilateral bicep curl and bilateral leg extension. All fixed, isometric, but we did this in 20% maximal voluntary contraction. Now why did we do that? Because at 30% hand grip, that's manageable. 2 minutes of bilateral contractions at 20% of your max, I'm telling you, the worst experience of your life, okay? Your legs are like doing this, it's locked up in the biodex and you start shaking like crazy. What an experience, but I'm telling you, it has an effect. So in that, we also started getting a question pretty regularly from folks at the American Heart Association, and we also started getting a question from folks from the American Cardiology, and they said, is this safe? Is this something that you can use regularly in the clinic? What if someone already has high blood pressure? Because if I do a squat, if I do a wall squat, if I do a plank, I'm going to see a significant rise in BP. So we meant to address that question. So we have another paper in review right now with the folks at Slippery Rock University. We're in that. We did bilateral blood pressure. We had a washout period where they were randomized to one of two groups, hand grip or aerobic cycling. Then they moved over to the other intervention after the fact, and we measured systolic BP, diastolic, heart rate, pulse pressure, mean arterial, and rate pressure product. So the purpose of this study was to compare real-time hemodynamic responses between isometric and aerobic exercise to say, this is the effect in real time, so that we can support that this is something you could deploy in patients with variable blood pressures. So in that, we also collected that data, and believe it or not, we saw in right and left arm that the biggest concern for folks, this rate pressure product, this is a marker, okay, a non-invasive marker of myocardial demand and how hard the heart is working. Aerobic exercise demands much more than the isometric component. And you say, yeah, that probably makes sense because smaller muscle mass, I'm recruiting a lot less. But ultimately, the takeaway for you folks is that you can do this training, even in those with higher blood pressure or those with normal blood pressure, and that robust response is going to be greater with aerobic training than it will be for isometric, which I think is unique because what is our first traditional intervention recommendation that we make for blood pressure? Go bike, go walk, go run, go lift. Well, we have data to support that if you exercise aerobically at this intensity, that it's a little bit higher in terms of demand compared to isometric hand grip training, which I think is interesting, but it begs the question. So on this slide for you, this is actually a part of that review article that we just submitted, where again, we made a comparison. We looked at all the data across HIIT, aerobic, combined training, resistance training, and isometric. We're also looking beyond blood pressure now. We're trying to see what other impacts could this have, okay? What other cardiovascular indices could we measure to see that we're having improvements in? So things like local vessel endothelial function, decrease in total peripheral resistance, changes in cardiac output, global longitudinal strain, so how hard the heart is working. We have a group in the UK that does a lot of echo work for us. And so they spend their time looking at echoes that we can contribute to this data to say the heart is actually improving its function by doing isometric training compared to other types of training. It's a wonderful group in the UK. They're amazing. They're wonderful collaborators and colleagues. And so that's the Edwards group, and they're awesome. They're the ones that reviewed that big paper and published that recently. But the goal here is that we're looking beyond blood pressure and we're addressing all these other things because there has to be more to this than just blood pressure, because that's what it was before. So we have to look farther. So all of you might be wondering, well, if I'm going to deploy such an intervention, how do I do that? And so this is also part of that review that we submitted. It's currently in revision right now. And in that, we have 3 primary modalities that seem to have the greatest effect. You've got wall squat, or wall sit, as they refer to it, leg extension, and hand grip. Those are the 3 primary modalities. It is accessible, it's affordable, it's really easy to do. I mean, assuming that these are things you want to do, like all things. But it's easy to engage in because these devices, these hand grip devices alone, about $15 on Amazon. Not that expensive, especially if you don't have, a double leg extension machine. Wall sit, just do that at home. All you need is a goniometer. That's pretty straightforward as well. So these alone, with their protocols in the middle, show you that we have 95% heart rate peak. We're doing 4 by 2 minute bouts, or 30% MVC. These 3 to 5 days per week, and then the impact goes on the far right side. So on systolic and diastolic pressure, those are the changes that we're seeing, and the number of trials for each of those. As you can see from this, hand grip is the most studied, and that's what we've been working on for the most part as well. With and without equipment, and it's about 15 minutes per day over the course of those 3 days. All right. Now, like I said, what I'm going to talk about next is actually a transition from BP. So we're going to talk a little bit about how this field is changing, because anytime in science and in research, you have to get a little creative, because you have to look beyond just one thing. Where we run into trouble is where we get so siloed in one area that we forget to look at other things, explore other options, and take opportunities as they come. And so that's what I'm going to talk about next here. So beyond blood pressure, and kind of a silly joke, but out of this world applications, is I have Spaceman, and I have a study that we're doing right now in collaboration with University of Pittsburgh Medical Center. And in that, they basically put people in a cold-induced sleep for about 5 days. They wake them up for 2 hours a day for 5 days. So it's a cold sleep period. In that, we want to see, does isometric training do anything for these folks where over 5 days you might see muscle wasting? That might happen. If you're that sedentary, you're going to see a decline in muscle function, muscle quality over that period as well. So we wanted to ask the question, could you do whole body isometric exercise and slow that decline? Simply by squeezing a ball between your hands, between your knees, behind your leg. So we wanted to explore that. So we're working with a group right now that's studying some of that work, and we're pursuing some research opportunities through NASA to say that whole body isometric training can enhance and improve the quality of that muscle. So in that, and this is probably going to be the most exciting slide for many of you, so I'm going to take a moment to talk about this. So in that, this is our isometric exercises protocol. Chest press, bicep curl, hamstring curl, hand grip, hip abduction, shoulder press, seated back extension, knee extension, pull apart, shoulder adduction, kick back, flexion, and wall push. We do that whole protocol during that 2-hour wait period. This is the isometric protocol, so this is what they're doing. But in addition to that, we're also supplementing. We're using a nutritional strategy as well. Are there folks in the room that have heard of Fortitropin? Again, I'm not a salesman, I promise you. So Fortitropin is a supplement. It's derived from eggs primarily, and it's a myostatin inhibitor. So it actually slows down the impact of the effect of myostatin, which is supposed to be, it's a negative regulator of muscle. So we want to see muscle growth. So if we want to slow down that negative effect, we can then inhibit myostatin using Fortitropin as a supplement. Okay? Now, for those of you that are probably going to write this down, it's really exciting work. It primarily started in dogs. There have been some randomized controlled trials more recently in older adults where they saw increases in both muscle strength and muscle quality when supplementing with Fortitropin. For our study, it made sense because this is a period of low activity, slight contraction, so we're getting activation of the muscle, but we're hoping to see a slow decline of the impact on that muscle as well. So this is the commercially available Fortitropin, so you can buy it, and funny enough, it's at yoked.com, believe it or not. But that's just kind of a play on the eggs pun. So yoked.com, and then with EIM, our electrical impedance myography, we're looking at that muscle quality in these folks that spend time 5 days in bed to see the impact on muscle structure and function. But we're pairing them up. It's too early to tell what that data looks like, but we're excited. And it's kind of some fun work that we've been working on just recently. But it's a great group. They're doing some really cool stuff, and we're hoping to expand this also into the space of like intensive critical care. So folks who have had maybe a heart attack that are stuck in bed, have had a massive heart attack, or maybe had heart failure or heart stop. We want to make sure that we can get them back up on their feet sooner, and so maybe a whole body isometric protocol might be the way to do that. Just a couple more slides here, folks. So the other thing I just want to take a moment to acknowledge is that some ongoing and future directions that we're doing at Pitt as well. And if this work excites you or interests you, my colleague right there, Dr. Sally Sherman on the left, is doing some of this work as a therapy option in the yoga space. So one of our ongoing studies, we're doing a pilot trial through the Pepper Center, so older adults with hypertension. We have them doing our hand grip protocol, but in that they're also just taking steps per day. No prescribed intensity. We have them with a pedometer. They walk around and try and improve 6,000 to 8,000 steps per day. And through that period, we're then having them do 3 days of the hand grip training because we want to see is there an additive effect of hand grip. So if this work is something that excites you, I just want to put a quick plug in for our Masters of Clinical Ex-Phys program. It's a program that I teach in. And it's some of the work that I'm working on with Dr. Sherman, where we're also going to add yoga into this equation to see as an additional additive supplement, what are the benefits that we can take away from that. So that's our current project at the bottom. But we're looking at the impact of non-traditional exercise interventions on these subclinical markers of CV. And then comparative effectiveness trials to say this is no worse than anything else you could be doing, and it could be better. We're looking at mechanistic explorations, and then hopefully with endorsement from the ACSM, AHA, and ACC, that we can continue to support the impact that isometric training can have in the future of exercise prescription. I will say this just really quickly. If anyone has any questions or follow-up, anything that I talked about today that they'd like to talk about more, or have anything that we can't get to a little bit later, that is my email address, so bgordon@pitt.edu. Please email me. Please reach out. I am more than happy to answer questions, especially from excited students. This is something that excites you and you want to explore this further. This is work that is ongoing that we're doing at Pitt, and it's something that our master's and undergrad students get to engage in at all levels, which is really cool. So if that's something you want to talk about more, I'm more than happy to discuss that as well. So in conclusion, what's your takeaway for today? Well, isometric exercise may lower blood pressure as a singular modality, but perhaps combining it with other types of activity may be most effective. Late-breaking evidence might give patients with hypertension a wider range of treatment modalities to choose from. This flexibility may improve long-term exercise adherence. Other applications are on the horizon. But more than anything today, folks, I just wanted to share with you something that maybe you didn't consider, maybe you didn't know about, but it's something that we're actively exploring, and it really excites us in this research space that we hope to continue providing patients with alternatives and options to manage their blood pressure more effectively. With that, acknowledgments, thank you for your attention, and I'll take questions if you have them.
You had the one study that showed that the grip strength was safe, right? So is this safe?
Yeah.
What about the wall sits, like and planks or others? But with the grip strength, smaller muscles, the wall sit, you're recruiting a bigger part of the body, more muscles. Is that safe?
That's a great question. So I want to address your question first by saying, with safety, that's a difficult thing to address, right? So with safety, you have to do a safety trial, as it were. By safe, what we mean is that in terms of myocardial health or safety, or putting someone at risk, they're within the guidelines of what is considered safe by the ACSM. That's what we use in terms of the cutoffs. Now that's a pretty high number. So 250 millimeters of mercury systolic would be within that safe range. Now, to actually answer your question in full, we have data, not our group, but the Edwards group has data with wall sit and plank that shows that their rate pressure product is higher than ours, but is still below aerobic training and below HIIT training. So, and even if you're doing those other types of interventions, whether that be wall sit or plank, the rate pressure product, which we use as an indicator of myocardial demand, is still lower than the cutoffs for ACSM and lower in many cases of doing high intensity aerobic training. So those indices are within the ranges of what is considered safe. Does that answer your question?
Yeah.
No, it's a great question. I mean, it's a great thing to address.
Yeah, man, I was just curious about the protocol slide.
Yeah.
This could be a really silly question, and I'm just missing something here. Can you just explain to me at least, what's the 95% heart rate peak? Is that, are you shooting for that, or is that you should set that?
Yeah, that's a great question. Yeah, no, thank you for bringing that up. So for those that are outside this space, what we talk about in terms of 95% peak, this is done with an incremental wall squat test at baseline. So anytime you do one of these interventions, you have to use a baseline test to see where do I start off, what is my response going to look like. So when we use our hand grip, so to establish the framing here, hand grip, you squeeze as hard as you possibly can, and then we take 30% of that value. With the incremental wall squat, you basically have them start out standing up, and they slowly, over time, work their way out down into a deeper and deeper squat until that person elicits a 95% of heart rate peak. Whatever that joint angle is, that's their prescription. And so whatever joint angle, joint angle, especially my words, joint angle achieves 95% of that heart rate peak, that's the prescribed angle. Now, over time, does that mean that might have to get deeper because we see a training adaptation? Yes. So you could do an incremental wall squat every couple of weeks, every session. Really just kind of boils down to what you want to do. We do MBC testing before every session because we've actually seen improvements in grip strength of 5 to 10%, even in the non-working arm, just by doing this type of training as well, just as a response. So we do those assessments every single session, whereas with an incremental wall squat, you might do it once a week. Answer your question?
Yeah, perfect, thank you.
Yeah. Dalton.
Yeah, so in your research, have you ever found any issues in the protocol with arthritis, osteoporosis? How would you go about adjusting that?
Yeah, that's a phenomenal question. So one of the biggest arguments that I've made in some of the papers that we've submitted is that we work mostly with older adults. So that's actually the area that I spend most of my time in, is older adults with hypertension. And so believe it or not, the biggest argument is that hand grip may be the best modality for those folks because doing the wall squat or something that requires more equipment or knowledge is a little bit more challenging. So in that, someone who has biomechanical limitations, those who have functional limitations, or let's say cognitive limitations, so we've actually started to explore some folks with Alzheimer's, not me personally, but a different group, is to rely on something that does the least amount, or that requires the least amount of effort, I think, but still can reap the benefits. So that's why we say, across all these modalities, something like hand grip still has a measurable impact, but wouldn't mean that someone has to go and do a wall sit or a plank or a squat or something that might put someone at risk who has arthritis or other biomechanical limitations or an impairment of some kind. So we can still get the benefits, but let's say it might take a little longer. It might take 6 weeks instead of 4, or it might take 8 weeks instead of 6, depending on what interventional strategy you use. So in that, I think I would say you try and meet someone where they are, but to give them an option, I think would be the goal. And say, what are you comfortable with? What are you capable of doing? What are your limitations? And then give them an option of saying, well, we can do hand grip, or we can maybe try this, and see how that works. But that's been my biggest argument in saying hand grip is for everybody, whereas some of these other modalities may be appropriate for those in the elevated space, but maybe they're a little on the younger side who can get away with doing some of these more advanced techniques. Answer your question? Yes?
I'm sure this probably depends on the population, but what do you think is the minimum time period required to start to see significant benefit? And then kind of follow up on the
That's a really good question. So with exercise, resistance training, aerobic, there's a post-exercise hypertension. So we tend to see a drop that can sometimes persist up to 24 hours after a session is done. Our data actually shows that the PEH is not so prominent with isometric hand grip training at least. So in some of the hand grip work that I've done, that response after the fact within a 24-hour period, pretty negligible, not much at all. We've seen effects early as 2 weeks, but about 4 weeks is typical to see that initiation and a robust response. That group that did a full year saw a plateau, I think, around 4 or 5 months, in which there was no further reduction. But then after the training had stopped, that rise back in BP was still delayed, similar to what we saw over our 3-month program. Yeah, that's a great question. We're not seeing the same post-exercise hypotension response that you would get with the traditional form of training, but give or take, it's about 4 weeks where you can start to see early changes. Yeah.
Hi. So I know for seeing people with hypertension just more and more in their ages now.
Yeah.
But so I was going to ask. With I know you're using these for people who already have hypertension, but do you think there's preventative ways that this can be done?
Oh, yes. I would love to do a study in those that are kind of on the edge or in the elevated space. To my knowledge, no one has done it as a preventative tool. What we have seen is there are reductions that are significant even in normotensive populations. So even in those that have normal blood pressure, 4, 6, 8 millimeters of mercury, you're still seeing a reduction in those folks. So they may have come in at 116 and then they're out the door at 110 or something like that. So if you were to do this over time, or is there a minimum threshold where you do it for 4 weeks and then you do it once a week, that's an open door. That's actually an underexplored area, and I think there's a lot of room for us to continue looking at this. A lot of the data has been very siloed into one area, which is those with hypertension or those that are pharmacologically managed. I think that as a preventative tool, it would have a pretty considerable impact. Well, you'd have to do probably a multi-year study. I've even thought about having grad students that I work with, just almost doing it as a convenience sample and saying, at the beginning of the year, this is when you started grad school, this is where you were. Some people do 30%, some people do 10%. Are we seeing an improvement in your blood pressure or control over that year period? I don't know. Your guess is as good as mine. But it's a great idea. It really would be a wonderful question to ask. But I don't have the data to share. Yeah. But if you want to do the study, let me know.
Okay.
And then we'll go back.
I'm sorry to say this early, but again, thanks for your presentation and talk and your information. I just think this is so cool that you're showing just these are potentially more accessible modalities that non-traditional that are having mega impacts. Really kind of more selfish question. It's related to the hand grip thing.
Yeah.
What do you think? Are there any benefits to dangling from a bar that might translate into some blood pressure responses?
I would say that that's probably not too far removed from a similar exercise, to be honest.
Sure.
Because grip strength is all similar in that way.
Yeah.
So, believe it or not, where this work started many moons ago was in fighter pilots. And so those that were gripping the controls, in certain Gs, saw reductions in BP pre and post flight. And so the harder you squeeze and the longer you were squeezing, we saw reductions in BP. So using the same idea, the same principle, if you're hanging from a bar, I would say that is not far removed because the shape of a dynamometer would be very similar. Yeah. Let's go.
You don't need to ask that question.
Let's do a study.
All right.
Yeah.
This question is my anyway.
I know there's a question back. Yeah.
For someone that's been a type 1 diabetic for a long time, do you see any correlation to anything in your results that would suggest you have to treat diabetics differently?
So I love that you asked that question. Very early on in my PhD, we actually tried to explore this using oral glucose tolerance testing to see if there was an impact with like the bilateral training. We didn't see much of a response, but I think that's because we were using people who didn't have diabetes. I would have to say it's unknown, but my guess is that it maybe is different, but I don't know for sure. Most of the space is in cardiovascular, heart failure, and in pulmonary patients. But as far as being a metabolic issue, that is an unknown. And unfortunately, I can't say one way or the other that it would have to be treated in a different way, but I also can't say that that's not possible. It's a great question. I don't know. I'm not sure. Need studying. I'll say that. Does that answer your question?
Yes.
Okay. Sorry, I don't have a better answer for you. I wish I did.
All right, thank
Cool.
you.
Thanks.
Go ahead and take 5 minutes, walk around, get up, stretch, and we'll start the next session in about 1:55 or so. Okay? Department of Health, Nutrition, and Exercise Science. And he does a lot of research on nutrition, sport nutrition specifically, and today he's going to be sharing about creatine.
Thank you.
The only thing standing between you and going home is me. I appreciate the kind invitation, and I want to say thank you to my host for having me. It's been a wonderful visit, a wonderful meeting for me. Thank you all for giving up Saturday to come and listen to more schoolwork, essentially. It's very impressive. So I'm the chair of Health, Nutrition, and Exercise Science at Messiah University. We're a very similar type of university to Grove. My department has health and physical education, sport management, nutrition and dietetics, and applied health sciences with concentrations in exercise science, pre-physical and occupational therapy, and pre-med. Additionally, Messiah has graduate programs in nutrition with a dietetic internship, in athletic training, clinical doctorate of physical therapy, and a graduate degree in occupational therapy as well. So we're all about the allied health sciences at Messiah. Briefly, before I begin, I should do some sort of a conflict of interest slide. I take a bit of a different approach to the conflict of interest slide. For most people, this is just a list of funding that might influence the quality of their work or their presentation. My slide represents anything that might cause any conflict or any bias to creep into my presentation. So what should you know about me? I've been on creatine since 1992, which I think is older than most of the people in the room. I've published and presented all over the world on creatine as well as other dietary supplements. I've been funded by the National Institutes of Health, corporations, foundations, all different entities to do research on creatine and other dietary supplements. I currently have no research funding. Occasionally people pay me to do talks like this, again, so I've received some reward for actually talking about dietary supplements, including creatine. I'm currently on the Scientific Advisory Board for Alzchem. They are a creatine manufacturer. In my defense, I studied and published on creatine for over 20 years before Alzchem asked me to serve in this role. And I'll do my absolute very best today to deliver just the facts and my interpretation of the best quality research. And I'll do my best not to let too much bias creep into the things we're talking about here today. So we're talking past, present, and future of creatine. So I think we need to go way back to the beginning. And that's the first publication, 1832. Wouldn't it be awesome if your professors looked like this? Dr. Michel Eugene Chevreul discovered creatine and revealed his discovery in a paper published back in 1832. So the first point, we've been studying creatine as a nutrient, as a metabolite for almost 200 years. This is not new. Creatine was the hottest research topic in nutrition and metabolism throughout the 1800s and early 1900s. And there's even an entire textbook dedicated to creatine published in 1928 with over 500 references just on creatine. Creatine supplementation is also not new. Some of you may have heard in a historical lecture, the great chemist, Justice von Liebig. Von Liebig published an extract of meat supplement marketed and sold in 1847. This was a meat concentrate. You can judge for yourself what this must taste like from that spoonful of booze up there. But creatine supplementation as a marketing dietary supplement, that's not new either. And research on creatine supplementation is 100 years old as well. Alfred Shanouton and then Lauren Guy published a paper in the Journal of Biological Chemistry back in the early 1900s where they fed their research volunteers creatine and measured how much creatine came out in the urine. And what they were able to observe is that some of the creatine disappeared. Put it in the body, it didn't come out of the body, which means it went somewhere. They didn't have the technology to figure out where it went, but you could guess it was building up inside skeletal muscle. So creatine research not new, creatine supplementation not new either. There's a few more pieces to the puzzle historically that are important in the creatine story, although indirectly. If you can imagine, creatine was studied for 100 years before we discovered creatine kinase, before we discovered adenosine triphosphate, and before we discovered the entire CK reaction, which is pictured at the bottom of this slide, which most of you know when phosphocreatine donates its phosphate to ADP, rephosphorylates it to ATP, and gives us energy. So there was 100 years of research about creatine metabolism without even knowing what it was doing inside the body. Another really groundbreaking event in creatine research was the refinement of the muscle biopsy technique by Jonas Bergstrom and Eric Hultman. This didn't happen until the mid-1960s. Up until this point in time, it was animal research only. You had to sacrifice the animals and figure out what was inside their muscles. After the 1960s, we could take a look inside a live human's muscle, pre and post exercise, pre and post dietary manipulation. So for the 60s and the 70s and the 80s, what we were really doing was figuring out what happens to creatine and phosphocreatine under the stress of heavy exercise. And a lot of the research that's featured in your exercise physiology textbooks, for instance, came from this time frame where these numbers that we often take for granted, how much glycogen is in your liver, how much glycogen is in your muscles, it all came from Jonas Bergstrom and Eric Hultman in the 60s and the 70s. Now, in terms of the modern era of creatine supplementation, what I call the Big Bang of creatine research came in 1992. This was a paper published by Roger Harris, Karen Soderlund, and Eric Hultman. And it was a simple, descriptive study. They just fed people creatine, measured creatine in their blood, measured creatine in their muscles. But we learned a lot from this investigation. We learned that oral creatine supplements are absorbed. They increase in the muscle, so you can alter your muscle creatine content. We learned that people with the lowest levels of creatine in their muscle have the biggest and best response to the supplement. We learned that there's a huge amount of variability in the response to the supplement. And we learned that exercise can enhance muscle creatine uptake, all from one paper. This is really where it all started from a research perspective. Now, having said that, you should understand that science often moves slowly, sometimes more slowly than we like. Okay? So by 1992, athletes were already using and admitting that they were using creatine supplements. Two great Olympians, Linford Christie and Sally Connell, admitted to the media that they were taking creatine supplements in '92 before Roger's paper was ever even published. It's important to be open-minded and not discount the experiences of athletes and coaches. And I can tell you from personal conversations that I've had, I'm aware of coaches who were experimenting with their athletes in the 1980s and even back to the late 1970s with creatine supplements and precursors to creatine used as dietary supplements. To make a long story short, and this is my little Dr. Rawson reminder here, sometimes athletes know first, sometimes coaches know first, sometimes gym bros know before anybody else. The flow of knowledge doesn't just go from me, Dr. Rawson, to the practitioners and to the athletes. That flow of information goes both ways. What I see in the gym, what I see in the field informs my research, just like it should go from research to real practitioners. Sometimes the scientists get there a little bit late. Okay, so we're talking about the interconversion of 3 different compounds here, primarily creatine and phosphocreatine. Your muscles are filled with creatine and phosphocreatine, where they're used together to make ATP to support energy production. Both creatine and phosphocreatine are spontaneously broken down to creatinine. That's the breakdown product. And then creatinine is excreted by your kidneys. Clinically, some of you may know that we use creatinine as an indice of renal function. That changes a little bit if your muscles are loaded with creatine. But that's the breakdown product. We're mostly talking about creatine and phosphocreatine today. All right, what can I tell you about creatine? Creatine 101. 95% or more of the creatine in your body is inside your skeletal muscles. And daily creatine turnover is about 2 grams per day. This is an estimate. They're all different shapes and all different sizes. This is a general estimate. 2 grams per day, meaning that we produce about 1,000 milligrams of creatine per day, and we eat about 1,000 milligrams of creatine per day. 1 gram endogenous, 1 gram exogenous. Creatine is almost completely contained in meat and fish, which means if you're vegan vegetarian, your exogenous creatine intake is 0. Now it's a non-essential nutrient, so that if your dietary creatine intake is in fact 0, you don't get sick and die. You don't develop a deficiency disease and die. Right? This is a non-essential nutrient. The endogenously produced creatine makes up for whatever's missing from the diet. However, if you are a vegan vegetarian, you eat no meat, you eat no creatine, your blood creatine I expect to be lower, your muscle creatine I expect to be lower, and even if I were to just place you on a vegetarian diet, within 3 weeks, your muscle creatine levels would drop significantly. So dietary creatine is important as well. Now, how much food do you need to eat to get to supplemental loading doses of creatine is an interesting question. A question I like my students to ask is, can I do this with food? Do I have to take the supplement, or can't I just do it with food? For a proper loading dose of creatine, you would need to eat about 12 pounds of raw meat per day. There's a couple big guys in the room and they're thinking, I will give it a shot. Right? I'll try. But can you do it? Yes. Should you do it? Probably not. And I don't think you will. So the picture there is 12 pounds of raw meat, or 20 grams of encapsulated creatine, or 20 grams of creatine powder. Cooking degrades some of the creatine that's in food. You're probably not going to be able to modify or increase the creatine content of your muscles through dietary sources. I don't know how many times a day you eat herring, but that's probably not going to happen either. There's only so much lean meat you can consume. So when we talk about altering muscle creatine levels, we're pretty much talking about supplemental creatine here. So some of the basics that we've learned since the 1992 paper by Roger and his colleagues have revealed how much creatine you should take, what type of creatine you should take, whether or not it works, and what works actually means, how it works, and then we've learned a fair bit about safety as well. So that's where I want to spend the next few moments. Okay. Creatine monohydrate supplementation. I'll comment on this in a bit, but when I say creatine supplementation, I'm talking about creatine monohydrate supplementation, because that's where 99% of the safety and efficacy data are on creatine monohydrate. We'll get back to that point in a minute. you can take about 20 grams of creatine per day for 5 days, and I would expect your skeletal muscle creatine levels to increase about 20%. That's an average. Okay? For you, it might be 10%. For you, it might be 15%. And for me, it might be 45%. This is largely based on your starting levels. You should think of this as like a gas tank analogy. Right? If you've got a 10-gallon gas tank, you've got 8 gallons in the tank, you can only fit 2 more in the tank. If you've got 9 gallons in the tank, you can only get 1 more gallon in the tank. Okay? So a lot of this is driven by your starting levels. 20 grams per day for 5 days will increase muscle creatine levels in all of us, small, medium, or large responses. To maintain that, a smaller dose is needed, somewhere between 3 and 5 grams per day will maintain that 20% elevation for as long as you want. Now, let's say you don't want to deal with 20 grams per day for 5 days. That's 4 servings per day. This stuff is not very soluble. You have to figure out how to hide it in your food. If you stir it in your Gatorade, it just sinks to the bottom like sand, ruins your Gatorade. So if you're not really interested in doing it 4 times per day, you could just eat 1 scoop, 3 to 5 grams per day, every day, and then in 30 days you would get to the exact same level of muscle saturation. So short-term high dose, longer-term lower dose, exact same level of muscle saturation. Just matters if you're in a hurry or not. Okay. Now, at some point in time, we have to talk about the 5% creatine is not in your skeletal muscles, and most of the rest of it is in your brain. We'll talk later on this afternoon about the effects of creatine supplementation on brain creatine and brain performance. I can give you a general recommendation. I can say that there's some research to say that a similar supplementation protocol, 20 grams per day for 5 days, might increase your brain creatine. It's definitely going to be a smaller increase, somewhere around 5 or 10%. And I'm saying maybe because the first bulleted point comes with dozens of muscle biopsy studies, and the second bulleted point only comes with about a dozen research studies. Remember, no one will let me take biopsies of their brain, not in my human subjects review today. So brain metabolite research is a lot harder to do in live humans, a lot more expensive to do, we're always going to have a smaller pool of data to choose from. But we're thinking right now that a similar supplementation protocol might be able to increase brain creatine as well. More on that in a bit. Okay, there's our supplementation protocol. If I take creatine and do a proper supplementation protocol, what sort of performance enhancing effect should I expect? I like to describe creatine as a training aid before I talk about it as a performance aid. What I mean by that is, I think the best use of creatine is to enhance your strength and conditioning workouts. We published a paper some years ago. The top graph is 1 RM, 3 RM, and 10 RM strength. The bottom graph is muscular endurance. When I give people creatine or a placebo, have them do their typical strength and conditioning workouts, people ingesting creatine get much stronger. So an 8% difference above and beyond traditional resistance training, comparing people lifting weights and taking a placebo versus people lifting weights and taking creatine. That's a massive improvement for a single improvement. In terms of muscular endurance, it's even a larger effect, about a 14% difference between resistance training and placebo or resistance training when ingesting creatine. There's a lot of different mechanisms hiding behind the scenes here, but most importantly, I think when you are creatine loaded, you just work harder in the weight room. More fuel in your muscles, you recover better between sets, you work harder in the weight room, and you get more out of your strength and conditioning workouts. So when people come to me and say, no, I want a sports-specific answer, will creatine supplements make me a better field hockey player? Usually I don't know the answer. Will it make me a better tennis player? Not sure. But if you believe that what we do in the weight room translates out onto the field, out into the court, out onto the pitch, then creatine is absolutely performance enhancing just based on the fact that it's such a powerful training aid and it enhances our ability to work hard in the weight room. So I think creatine is a fantastic training aid. In terms of actually enhancing performance, we have hundreds of investigations. The majority of these investigations are laboratory measures of performance, things like anaerobic cycling, things like the Wingate test, but there's also a large body of literature on swimming, on track running, on agility runs, things like that. We find that creatine supplements are effective, and they are especially effective when exercise is maximal, when it's less than 30 seconds, and when there are repeated bouts, which sounds exactly like what you do in the weight room, which is why it's so effective in the weight room. That's the most consistent body of literature. But the body of literature, and I mean hundreds of studies, is very effective on acute high-intensity exercise performance as well. That's where creatine is the most effective. It is also very effective when sprints are embedded in or following endurance-type tasks. There's some really nice work in this area with cyclists. And if you think of the Tour de France, hundreds and hundreds of miles on the bike, that's an endurance challenge. How does every stage of the Tour de France end? In a sprint. And what do they do during the stages? They sprint, challenge each other, they sprint uphill, right? So there's a few studies, very well done studies, that show that when sprints are embedded or following an endurance challenge, performance on the sprints is actually enhanced by creatine supplementation. So there's value here for athletes beyond the 100-meter sprinters, beyond those high-intensity sprint athletes. There's real value here for athletes whose sport, maybe certain soccer positions, is primarily endurance, but also involves a fair bit of sprinting as well. All right, how do creatine supplements work? This could be like a 5-hour lecture on its own, so I'm going to try and keep it down to 1 or 2 slides. Mostly fuel. I love the fuel analogy. Right? Your muscles are filled with phosphocreatine and glycogen right now. If I feed you a high dose of creatine, I can squeeze some extra phosphocreatine in your muscles. Just like if I fed you a higher carbohydrate diet, I would get more carbohydrate in your muscles. And in fact, if I simultaneously creatine load you and carbohydrate load you, the creatine sucks more carbohydrate, more glycogen into your muscles. Okay? So you're starting whatever activity it is you're doing with more fuel in the tank. Okay, so number one, how is this working? More fuel in the tank. Number two would be phosphocreatine recovery between bouts or sets of exercise. Phosphocreatine resynthesis. You can exercise hard enough to take your phosphocreatine levels down to 0. Then it will resynthesize and go back up to normal levels. This takes 3 or 4 or 5 minutes, depending what you're doing. When your muscles are loaded with creatine, phosphocreatine resynthesis or recovery is faster. So in between downs or plays in football, an absolute usefulness here. Not just in between sets of squats in the weight room, but in between certain types of plays, depending on the athlete and the nature of the game, we can really be helping people recover in between plays. I like to think of creatine as an adaptive nutrient as well. Now, the big adaptive nutrient is going to be protein. It's going to be amino acids. Your protein intake is going to have the largest effect on your adaptation to an exercise training program. But I think creatine's in the club here. If you review the literature on creatine and adaptation to exercise, you will find that raising the creatine content of your muscle really flips all of the switches into a direction that promotes exercise adaptation, meaning that the gene expression of a variety of different growth factors is enhanced when your muscles are loaded with creatine. Satellite cell activity is ramped up when your muscles are loaded with creatine. And a lot of people have talked about, creatine makes you retain water, and I heard that was bad. But actually, cellular swelling is really an anabolic signal. If you can get your muscle cells to suck more water into the cell, you are increasing glycogen synthesis, you're decreasing protein breakdown, you're turning on over 200 different genes that all of them look like they would improve exercise adaptation responses. So probably not as powerful as protein here, but I think creatine works through 2 channels: fuel before exercise, and then adaptation after exercise strength. So, if you're new to the creatine literature, or if you know people who are new to the creatine literature, I'm going to recommend a few open access publications for you. This is something I wrote a few years ago for the Gatorade Sports Science Institute. It's one of their Gatorade Sports Science Exchange articles. It's a brief, comprehensive review article, and it's designed at the practitioner, at the coach, at the physician. Tell anyone physicians don't have any nutrition or exercise physiology knowledge, and I want to make the doctors mad. But you all have way more knowledge than most medical doctors do already, right? They're not trained in this area. So this is a nice handout for clinicians, for practitioners, for coaches, for people who want the science, but they want it in a form that's very easy to consume. If you're interested in learning more about creatine, I'd start here. There's two massive tables in the article. One of them lists the different areas where creatine supplements have been very heavily studied. So exercises lasting less than 30 seconds, field tests versus laboratory tests versus resistance training versus endurance exercise. And the other large table in this article, which is online, goes through the different mechanisms. So cellular swelling, gene expression, phosphocreatine resynthesis, all the different ways that creatine is possibly enhancing the adaptive response to exercise or improving exercise performance. It's open access. It's a great jumping off point for people to start with. Okay, let's get back to that issue about creatine, all caps, monohydrate. There's this many creatine supplement products on the market. Now, I'm going to apologize that I might offend some of you who are taking some of the products that are on this slide. I'll apologize again to you in person later, but too bad. 99% of the literature is on creatine monohydrate. 99% of the literature on safety, 99% of the literature on efficacy. There's a tiny amount of literature, tiny amount of publications on those creatine products in gold. And then the ones on the bottom of this image, there's really no research whatsoever. Every single one of these manufacturers is offering you the same sales pitch here. Better absorption. Creatine monohydrate is absorbed above 99%. Can you do better absorption than that? No. And there's not even any research to back it up. Right? This article comes from the ISSN's position stand on creatine supplementation. All of these things are marketed based on better absorption, which they don't have data to show, better performance effects, which they don't have data to show. Right? There's simply no reason at this point in time to take anything besides monohydrate. The absorption is fantastic, and the safety and efficacy data are all there. Okay? So when I say creatine supplements, I'm always talking about monohydrate. All right, let's talk a bit about safety here. There are a few different areas of creatine supplements that have produced these incredible myths related to creatine's potential to be an unsafe nutrient. First of all, we're talking about a nutrient here. We're not talking about some sort of drug or some sort of exotic substance. We're talking about something that most good people in the room eat, and our muscles are already filled with it. So I never quite understood why people got so excited, but from a safety perspective, I can see how these myths have risen to gigantic proportions. And I'd like to point fingers and blame a few entities here. The media produces a fair amount of misinformation. On the bottom right is a newspaper clipping. 5 collegiate wrestlers died within a very brief period of time, some years ago. The entire history of wrestling, we never had any fatalities. And 5 young men died within a month of each other. Okay. USA ran this headline, deaths raise suspicions, two groups to look into creatine. You know, if you go back to the original morbidity and mortality report, none of these athletes were taking creatine. They were cutting weight. None of them were taking a weight gain supplement, right? They used very destructive dehydration procedures, very dangerous dehydration procedures. When they died, their body temperatures were above 108 degrees. Okay, what's the headline say? Creatine, right? So misinformation can come from some of our largest sources of media. But it's not just the media that gets it wrong sometimes. Right? On the top right here, renal dysfunction accompanying oral creatine supplements. Misinformation can come from medical journals like The Lancet. This is a case study where they decided on that title, but they probably could have just called this case study "A man with chronic kidney disease taking an unbelievably nephrotoxic drug started taking creatine and his creatinine levels went up." We didn't know what that meant. That was too long to use that title, so they went with this one, right? And now for the past 30 years, I'm dealing with creatine causes dehydration, creatine causes kidney problems. There are dozens and dozens of research studies in this area, in both of these areas, to disprove these things. But the myths live on. When there's misinformation about nutrition, at least for nutrition, it does not go away very quickly. And then on the left here, creatine, a culprit in Oregon compartment syndrome case where dozens of high school football players were hospitalized. Was it creatine? When you read these articles, it literally says things like, "We checked the school water supply to see if there was creatine." I can't believe it. Anyone in this room who read the exercise protocol and the conditions that they did this exercise protocol under, any of you would look at that and go, "That's a dangerous exercise protocol." I'm surprised everybody's not in court or in jail, right? Because this was clearly exercise-induced rhabdomyolysis. This was clearly exertional rhabdomyolysis. And they hospitalized a bunch of high schoolers. And the best anyone could do on the internet was scratch their heads and say, "I wonder if there's creatine in the drinking fountains." Right? To give you an idea, I'm just going to address the muscle issue now, but if you have questions, we can talk about the kidney stuff or the hydration stuff. To give you an idea of what's in the literature, what's published, despite the fact that these myths live on, I thought it would be a good exercise to show you how, despite what we learn from our texts and from PubMed, we still have to do a good job educating people forever and ever. This is from one of our papers. These are epidemiological studies, observational studies in collegiate athletes, and they're ingesting creatine, and thank goodness for athletic trainers, they do a wonderful job keeping track of our athletes' health and injuries. And we have, in athletes who are taking creatine, do we see more muscle cramps? One study, no, we see fewer muscle cramps, or no difference between the groups. Do we see more issues related to muscle tightness? No, we see fewer in the creatine group, or we see no difference between groups. Muscle strains, creatine supplemented people do better, or they do just the same. Total injuries, fewer, no difference. Contact and non-contact injury and missed practices and players lost disease. There's absolutely no evidence, and in fact there's evidence that when collegiate athletes ingesting creatine, there's either no increase in risk or there's even an improvement in their risk of injury profile. Now, if you've taken research methods or you've listened to your faculty, they've probably told you that observational studies and epidemiological type studies are on the weaker side. So we need some randomized controlled, double-blind, placebo-controlled clinical trials that have loaded people with creatine or placebo, then purposefully tried to hurt them to see if it increases their risk of muscle dysfunction. Well, we have those studies. So here's another talking point from little Dr. Rawson. Okay, everybody memorize that table. Good? Okay, this is just for visual purposes, right? All of these studies have measured outcomes that are indirect markers of muscle damage, okay? So muscle serum proteins leaking into the blood in creatine supplemented individuals versus placebo supplemented individuals who were subjected to some sort of exercise challenge, like an Ironman triathlon, pretty damaging, like high rep squats, like my favorite, 50 1-rep max eccentric contractions. Okay, if we're going to damage muscles in a lab, we're going to damage muscles in a lab, right? So what I'm highlighting here in red are all of the places where there was actually decreased leakage of muscle serum proteins in the blood, or less muscle damage in the creatine group. Okay, here's enhanced recovery of strength in the creatine group, and here's less delayed onset muscle soreness in the creatine. Now I'm going to cross off the top couple studies because those are just resting studies. They're very early studies, like take creatine and I'll measure what's happening when the blood just sits still. Okay, there's no exercise challenge in those three. The rest of the table, there's 12 studies of the effects of creatine supplementation plus purposeful muscle damaging exercise. 5 show no effect, and 7 show less damage. Now, a meta-analysis came out after our paper, and they said there's no statistical evidence that creatine reduces muscle damage or reduces inflammation or helps you recover from these types of exercise challenges. And I kind of agree, and I'll believe that. There's no evidence that there's an enhancement here. What this actually shows, and I don't think people really got the message, so I'll make it loud. There's no study, no double-blind, placebo-controlled randomized trials that have ever shown an increase in muscle damage from people ingesting loading doses of creatine and then having some really, really harsh exercise challenge. So between these controlled trials and the epidemiological observational studies, we have all the data we want to say, no, creatine doesn't cause muscle dysfunction in any possible environment that we can think of. It might be protective, maybe it's not, but it's absolutely not damaging. So where does the myth come from that creatine causes muscle dysfunction? Well, there are a few case studies, right? Never ignore case studies, okay, but place them in the proper context. If you think of the prevalence of creatine use, right, let's say 25% up to 100%, depending on the age and the sport. You're starting with high school athletes, collegiate athletes, professional athletes, international amateurs, global. We're talking about tens of millions of exposures here, and I have like 6 case studies. Okay, now perhaps creatine was the tipping point in these exact situations, but when you look at the mitigating circumstances in these case studies, you realize what you're looking at is exercise-induced rapid myolysis. Everyone is following an extreme layoff and then a massive amount of exercise. Or they're dehydrated, they're taking stimulants, doing a massive amount of exercise. Perhaps my favorite one is at the bottom. This was a large athlete who hit a tree skiing. That's a crush injury, that causes rapid myolysis. He went in for arthroscopic knee surgery with a tourniquet. Tourniquets cause rapid myolysis. He was huge and had to lie still on the table, right? Large people can get rhabdo during surgery when they're immobile. And I was also taking large doses of non-steroidal anti-inflammatories. Again, can cause rapid myolysis. What was in the title of the case study? Creatine. Right? Maybe it was involved, but this person really had every possible mitigating factor that could have precipitated this exercise-induced rapid myolysis. So out of millions and millions of exposures, I don't see a lot going on. I like case studies. I wish more students did well-controlled, prospective case studies where you measured all of the things that you know you should measure. I really don't care much for these retrospective case studies where someone shows up in the emergency room and they try to piece together a puzzle, right? And these continue to get published at a very, very slow rate. When I was preparing for this talk, I found this one, and I said, I wonder if there's any other case studies with a lot of mitigating factors like in this summary we did. And check out this one. Acute compartment syndrome of the leg caused by cocaine use, creatine supplementation, and vigorous exercise. Totally agree. All right. So I'm a muscle physiologist. That means I use my brain as little as possible. I think about my brain as little as possible, and I'm always trying to improve my muscles. But a few years ago, I got turned on to looking at nutrition as it may positively impact our brain health and also our brain performance and possibly our physical performance. So I'd like to spend the end of today's talk talking about creatine as it might affect other tissues in your body. So on the left, you have Rogers' landmark paper, Creatine Supplementation is orally absorbed, it increases your muscle creatine levels. And then in '99, Deschent and colleagues published this paper, Increased Total Creatine in Live Human Brain After Ingested Creatine Monohydrate. I thought, what a stupid paper to do. And I took it to my advisor, I was in graduate school at the time, and I said, look, creatine makes you smarter. We both had a good laugh and never read the paper for about 5 or 6 years. And then we started to think, maybe we should learn a little bit more about what our brain actually does. And it turns out the brain's very highly metabolic. It relies a lot on creatine and phosphocreatine to make ATP and for energy. And if I can modify my brain creatine levels with oral supplementation, I might be onto something really, really important here. So I went back and I picked up this paper and I compared it to the Harris paper. What we learned from Roger? We learned that oral creatine monohydrate supplementation increases muscle creatine. From the Duchenne paper, we learned we can do the same thing in the brain. From Roger's paper in '92, we learned we can increase skeletal muscle creatine by 20%. The Duchenne paper looks more like 8 or 10%. From Roger's paper, we learned that if you have low muscle creatine, you're going to have the biggest response to the supplement. From the Duchenne paper, we really couldn't figure any of that out, but we did learn that creatine levels are different in different spots of your brain, and there might be different responses to the supplement. We also learned from Roger's paper that exercise increases muscle creatine uptake, and there wasn't really any exercise involved in the Duchenne paper. But it was really interesting to go back and read this paper when I was a little older and think, there's a lot of work to be done here, and a lot of positive health outcomes. We can really do some impactful stuff. So we started thinking about creatine in the brain a little bit more seriously. I want to tell you that this is an adventure for me because, again, I'm a neck-down physiologist. I like skeletal muscle. That's cool to me. I never expected to study the brain or do research in the brain at all. So I had to learn that the brain is very, very different from skeletal muscle. First, most of the creatine in your body is in your skeletal muscle, and only a tiny amount is in your brain. So from a measurement perspective, it's really going to be hard for me to measure any increase when there's such a small amount in your brain in the first place. Your muscles are not where creatine is manufactured. Creatine is manufactured in other parts of your body, and then it's stored in your muscles where it's used. So your muscles are really designed to take up exogenous creatine. That's why supplementation works so well. The door is open for creatine to go into your muscles. Your brain, much more protected. Your brain, the blood-brain barrier does not want you to freely float dietary supplements in and out of your brain. So it's not the same as skeletal muscle at all. Excuse me. It's resistant to exogenous creatine, which makes these supplementation trials a bit more complex. Think about it. You want your brain to be protected. And the brain can manufacture creatine, so it doesn't need us messing with things from the outside. Muscles can't manufacture creatine, so the door's open. It's easy to get creatine from the outside into your skeletal muscle. I know that your muscle creatine changes in response to diet. I don't know anything about your brain creatine in response to diet. Not back in the 90s or the early 2000s. I have a little bit more data I can share with you today. I don't think brain creatine changes in response to diet. Some people will disagree with me. I don't think your muscle creatine changes in response to exercise training. I think if you train like a sprinter, you get a lot of wonderful adaptation to your muscle. Having more muscle creatine is not one of them. Training your brain, does that change your brain creatine content? No one really knows. There's maybe one paper in this area. And when muscles are rest, I know that your muscle creatine is very stable. That's why it's so easy for me to measure, and I can measure very accurately. This research is wonderfully reliable. I'm not sure if your brain creatine is changing right now as you're struggling to take notes and keep up and maybe dozing off and wishing you had more food or something like that. I don't know how much brain activity actually influences your steady resting levels of muscle creatine. There's work to be done. Muscle and brain are not the same tissue. We shouldn't think that they are. So a few simple questions for you. Can we increase brain creatine with creatine supplementation? What's been done since the initial Duchenne paper published in '99? I don't have hundreds of studies to share with you like I do with skeletal muscle because very few labs have the ability to measure brain creatine. Most of those labs are not interested in creatine supplementation. They're looking at other metabolites in the brain, or they're looking at the brain from a different perspective. They're not exercise science people. We know that the brain and blood-brain barrier are tough to penetrate. Okay? Some people have argued with me that the creatine transporter in your brain exists on the nerve cells. These are the blue balls there. People have argued with me that this creatine transporter exists on the brain cells, which means the brain cells are manufacturing creatine and they can exchange creatine. But people argue that that creatine transporter is at very, very low levels in the astrocytic feed of your brain, meaning the blood-brain barrier, meaning I can't get creatine in from the outside. Okay, exchange within, but not from the outside. And I would disagree with that, and I would disagree with that based on some very old data. So I went back to my office and I scanned an old graph for you, because I wanted to prove that I can get creatine into the brain under certain circumstances. These are children who have creatine deficiency diseases. It's a very rare genetic disorder. These children are very, very sick. They can't speak, they can't sit up, they can't function. They have no creatine in their brain because they cannot synthesize creatine. They're missing the appropriate enzymes. If you feed them creatine, you can rescue them from this horrible circumstance. There's even some thought that some children who were in the past diagnosed as mentally retarded actually were just creatine deficiency patients. Now this is a different access here. This is not days of supplementation, it's months. But when you refeed these children creatine, their brain creatine levels go back up towards 100, you exceed 100%. You can completely rescue them from this awful circumstance of supplementation. So I know I can get it in the brain, but this doesn't characterize most of the people sitting in this room right now. So there may be certain circumstances where the brain is going to be resistant, and other circumstances where the brain is much more open towards supplementation. Okay, what can I say about the people in this room? If I pull out all the creatine deficiency syndrome papers, if I pull out all the creatine in schizophrenia, creatine in depression, and I just have young, healthy individuals, and I feed them oral doses of creatine, there's a dozen papers, 9 of them have shown improved brain creatine levels. It's a small body of literature, but it's a consistent finding. Now, if we go back and we look at that original Duchenne paper, we see 3% gain, 5% gain, 13%. If we look at the different regions of the brain, we see 6%, 3%, 5%, and so on. It's definitely less than skeletal muscle. And there's really only two studies of direct comparisons. Oral creatine supplementation as it accumulates in the muscle and in the brain, and they both demonstrate that the response is not the same between the tissues. So this one paper from Solis and colleagues in 2017 showed that when you feed people creatine, their muscle creatine goes up. 10% was the lowest value in this study, 27.6% was the highest value. The same group, when they turned them around and put their head in the MRI, went from like 0% to 4%. Small gains with young, healthy individuals who don't seem to have their creatine brain levels challenged for any particular reason. It seems to be a smaller response. Now, why is this important? It's important because it makes our research very, very hard. We have to respect that muscle and brain are different. What I have for you here is research from a well-done study on creatine supplementation, creatine versus a placebo with muscle phosphocreatine as the outcome measure. These are the mean differences, so no change and significant increase. And then you have individual subject responses. So you see slight increase, slight decrease, but on this side you see the slope is almost unanimously pointing upwards. If I asked you which side was the creatine group and which side was the placebo group, would you be able to identify that it's this group based on the individual responses, that everyone increased muscle creatine a little bit, a medium bit, or a lot bit? That's got to be the creatine. Right? You'd be correct. That's placebo. That's creatine. Everybody responds, small, medium, or large. Now let's look at the same investigation from the same lab, 3 different regions of the brain. Notice that I've blocked out which side of the graph is creatine, which side of the graph is placebo. Pick a pen. Okay? I see increased brain creatine. I see just as many decreased brain creatine. I see some decreases. I see some increases. I I see a large increase, I see 2 large decreases. I see some flat lines and some decreases. Can anybody confidently tell me which side of the graph is the creatine group, which side is the placebo group? Faculty? No. And I'm not going to tell you. You're just going to have to go read the paper yourself, too. But I want you to understand that there's a lot of noise in there in these brain measurements. These are some data from our lab where we directly measure muscle creatine, and we measure brain creatine pre and post supplementation. And be careful here because I've stretched out the axis so you can see the difference. It's about a 15% average increase in the muscle, with everyone having a small, medium, or large increase. These are individual subjects. In the brain, I got a non-significant 2% increase. Look at the variability. 5 or 10% decrease, 5 or 10% increase. Right? It seems like under normal circumstances, it's very, very difficult to get creatine into the brain. But if you suffer from certain types of depression, if you have a deficiency disease, or a number of other circumstances, it looks like this might be a really, really valuable dietary supplement for brain health. And that's where I'd like to finish up with today's talk. Can we increase brain creatine levels with creatine supplementation? I'd say yes, absolutely. But place it in the proper context. There's huge variability in the response. Skeletal muscle is meant to take up creatine. Brain creatine is self-sufficient. The metabolic machinery is there inside the brain. It's resistant to taking up exogenous creatine unless there's some reason that your brain creatine levels have been depleted, which might characterize some of the people in this room. It definitely characterizes some of the populations I've worked with. Okay? If I can get creatine in your brain, what good things could possibly happen? Why am I even talking about this? Well, I think the outcome measure that we're looking for is an improvement in cognitive processing. Now, essentially I'm saying, can creatine make you smarter? Right? Can creatine improve your performance in cognitive processing tasks? Now, prior to updating this lecture, there were 16 studies, not hundreds, but 16 studies of creatine supplementation and cognitive processing outcomes. 13 of them showed an improved cognitive processing, 3 of them showed no effect. When I went back and reviewed some of the newer papers, there's now 19 studies, with 15 showing a positive effect and 4 showing no effect. It's a small body of literature compared to hundreds of muscle studies. That's pretty convincing. And I'll tell you why I'm very optimistic about this body of literature, even though there's only 19 studies. Every single one of these studies was completely different. There's old people versus young people. There's vegetarians versus non-vegetarians. There's people who are stressed. They're sleep deprived. They're overloaded with exercise. They've been given some sort of brain challenge, something to make them mentally fatigued or physically fatigued or both. Different dosing strategies, different duration of supplementation. And with all of that noise, I still get 15 positive studies saying that creatine supplementation can improve cognitive processing outcomes. That's very impressive to me. Now, what will this body of literature look like in a few years? I don't know. One of the newer studies was actually just an acute dose. Some of the professional athletes I've spoken with insist that if they take a dose of creatine 5 grams before a game, before they play, they feel more clear. They feel better cognitively. Even if that's a placebo effect, I'm kind of happy about it. But I always thought that would be silly, but one of these new studies is an acute dose with improved cognitive processing outcomes. It's kind of a very exciting time to be in this area. So good reasons to increase your brain creatine levels for sure. Now, if you're interested in this area of research, you can look me up on PubMed. People like Darren Kandow or Scott Forbes. There's a lot of big reviews on creatine supplementation and cognitive processing outcomes. Most of these are open access, so you wouldn't be blocked or have to pay for the articles or anything. There's enough research for us to confidently say we think there's something good going on here, although there's a lot more work to be done in this area for sure. So, last bit of today's talk, I think will resonate with some of the people in this room. What sort of circumstance would any of this group get into that might cause a reduction in brain creatine and where they might really benefit from creatine supplements? And that's a mild traumatic brain injury. I've always shocked in this picture of poor Tony Ferguson's face. All right. If I didn't put up a metabolic pathway, Philip would yell at me. This is serious stuff. Look for the color red here. This is the neurometabolic cascade that happens when you get smashed in the head. This is a mild traumatic brain injury. The red is the overlap between the neurometabolic cascade of concussion and creatine biology. So when you get hit in the head, your brain creatine decreases. That sounds like a natural match for creatine supplements. But also, there's an increase in membrane permeability. There's calcium rushing in. There's oxidative stress. There's mitochondrial dysfunction. There's all these horrible things that creatine mitigates. Creatine can improve. There's basically this massive energy drain, like a wave of depolarization that comes across your brain when you get a brain injury. And creatine helps rescue the brain, at least in theory, with all of the arrows and the cool metabolic pathway. It looks like creatine could really play a role in rescuing you from this massive energy drain, this kind of cellular energy crisis. What can I offer you besides just a metabolic pathway? Well, I can offer you some animal data. I never talk about animal data. I don't like animal data. I don't do animal research. I would much rather take biopsies from people and hit people in the head and do stuff like that. Which no one lets me do, but you get the point, is that if I have animal data, it's still not human data, right? But in this case, it's kind of important, right? Because the creatine supplementation traumatic brain injury data in laboratory animals is really convincing, okay? Mice and rats, 36% and 50% decrease in damage in creatine-loaded laboratory animals. 36% and 50% decrease in damage in creatine-loaded laboratory animals. That's a massive reduction in damage from a nutrient that's readily available, right? There's a long list of other good stuff that's going on if you want to go back and get this old Sullivan paper. Improved mitochondrial potential, and fixing all the membrane problems, reactive oxygen species, calcium, maintaining ATP levels. Basically, the cellular energy crisis that happens, we reverse it in an animal model. But it's still just rats and mice. Do I have any human data? I have 2 investigations. These are open-label clinical trials. They're done in hospitals, not double-blind, placebo-controlled. These are children who have traumatic brain injury, not mild traumatic brain injury. These are very, very sick kids. Some of them died during the investigations. We don't know much about them. I'm sure there were probably a lot of car accidents involved in these cases. When we feed them loading doses of creatine in the hospital for 6 months, the graphs show massive reduction in headaches, massive reduction in disease, massive reduction in fatigue, which are all things most people recognize as some of the debilitating effects of concussion. Okay? There's a lot more in these papers. Post-traumatic amnesia, basically in hospitals, they measure everything under the sun in these types of studies. Right? Post-traumatic amnesia, how long they were intubated for, how many days they were in the ICU, self-care, their ability to communicate, personality, behavior, mood. Everything was improved in these young children ingesting large doses of creatine. And that's meaningful to me. It's not double-blind, placebo-controlled, right? But it's not animal data, it's human data. A colleague of mine just completed double-blind, placebo-controlled concussion trial in collegiate athletes. He hasn't even submitted it to publication yet or analyzed it, but those data are coming soon. Now, I have animal data, I have clinical data, and I have some really cool observational data. I'll share with you one paper, which you might want to go back and read. There's one group that has access to retired NFL players, unlimited access. So whatever their data show, these studies are important because they have access to the population we're all interested in. These are people who've had repetitive injuries, repetitive head injuries. Some of them are symptomatic years later, years into retirement. They played sport at the highest level. I really want to know about these people. In this investigation published by Rawson and colleagues, they isolated retired NFL players who had been exposed to repeated head injuries but were still symptomatic years later, they had depressed brain treatment levels, indicating that some of this metabolic dysfunction could last decades. And again, it could possibly be rescued by a simple little dietary supplement. So there's a lot of great stuff going on here. You can go to this paper and you can argue the correlation's not very high, and I don't like that scatter plot. But very rarely do we get to study the group that we all kind of want to study, and that's elite athletes. So, what sort of recommendation can I make for creatine and concussion? Is the evidence circumstantial? You could say that. Okay? I know that creatine is neuroprotective from a bunch of studies. I know that mild traumatic brain injury decreases your brain creatine levels. I know the animal data are very positive, even though we're not rats and mice. I know that the traumatic brain injury in children data are very, very positive, even though we're not little kids. And the NFL data, it really is quite striking to me that indicates this is something that can be very, very long lasting. If you put that with the cognitive processing data, does this add up to a recommendation for athletes to take creatine based on brain health? I'm not sure. The way I look at it is excellent safety profile, excellent muscular benefits. If you are a high-risk athlete, you've had previous concussions, you're playing a sport where you're at risk, then I almost think you're being a bit negligent if you're not having an open discussion with athletes about ingesting creatine in terms of mitigating damage from concussion, based on largely circumstantial evidence, but for the low cost, the widely available and inexpensive excellent safety profile, I really think we have to look at this quite closely. We'll make this the last slide because we're running long here, and I'd love to answer a few questions. Not everyone here is going into sports science or sport nutrition or strength and conditioning. Some of you are going to go into physical therapy, you're going to go into occupational therapy or clinical exercise physiology. You should know that a lot of the work we do in sport nutrition has great applications for patient populations. And I hope you begin to think like that. It took me a lot of years to get here, but now when I think about protein, when I think about muscle building, when I think about muscle atrophy, when I think about energetics, I think about patient populations and older adults just as often as I do about athletes. So there are dozens and dozens of studies in creatine supplementation in patient populations. We know that creatine supplementation is effective on a variety of different patient populations, most spectacularly in muscular dystrophy patients, possibly effective in mobilization or heart failure patients, and a number of other populations have been studied as well. So for the clinical exercise physiologists, there's a whole other lecture waiting for you. But I'm going to stop there. I'm going to say thank you for your attention. I'd love to answer any questions you might have.
Last quick question.
Sure.
What do you do if you work with weight class-oriented sports, with like weightlifting, wrestling, judo, whatever?
That's a great question. Okay, weight class athletes. You should know that you will gain weight when you take creatine. It is sucking water into your muscles, but it's a little different from carbohydrate loading. Like if I stop eating carbohydrate today, I'll be like 5 pounds lighter by Monday. Right? If I carbohydrate load, I'll be 5 pounds heavier by tomorrow. With creatine supplements, that water is bound inside the muscle cell. So that increased weight and increased muscle water is there until the increased creatine is back to normal. We published a case study some years ago on a high responder, and after a month off creatine, his muscle creatine levels were still 25% higher, and he was still several pounds heavier. And you could be, if an athlete's close to a weight class, you could be putting them in a bad spot. They are not going to lose that weight. It is not coming off because of the way that water is bound inside the muscle. So if you're close and you insist on going down a class, then maybe creatine is not the right supplement for you.
Well, that's the one. There's some of you who asked me that very question at the Big Ten Wrestling Championships just last weekend, and he said that there's a type of creatine that you can take that doesn't affect that water retention as much, and I'm calling BS.
Yep. Please call BS loudly and clearly. On that image of on Mount Creatine there, that particular product is up there. No data on safety, no data on efficacy, no data on weight gain, water retention, muscle creatine uptake, or performance. We have to stop being so easily fooled, you know? It's like, you know, hey, you want to try some vitamin C citrate? It's 50 times absorbed better. That sounds foolish, right? But with sport nutrition, we want what we want. So athletes are very susceptible. There's no supplement out there that does any such thing.
Beware of the internet.
Beware of the
You know,
internet.
people. I'm telling you. There's
Yeah.
too many geniuses out there that have all the answers, but they don't.
But if you want to know what your athletes and your parents and your patient populations, you want to know what they're reading, it's not PubMed. Right? I used to tell my students, stay off Google, get on PubMed. But then we had no idea what anyone was asking us about. So you have to spend a little time on social media, a little bit of time on Instagram, figuring out where the misinformation is coming from to be able to combat it effectively. Just don't get lost down a TikTok. Other questions?
So you mentioned that there's some regional differences in creatine intake.
Yeah.
What region specifically? How does that affect function? And then does uptake in one particular region lead to decrease?
She asked me a 12-part question. It's like 3 o'clock on Saturday. We don't know yet because, or we don't know with confidence because we have people who have access to an MRI, people who care about creatine work who have access to an MRI, and then people who can measure multiple areas of the brain. There's 2 labs in the country who could do that work, and you know, it takes a lot of money to do these scans. So it looks to me like the starting levels of creatine are different in different areas of the brain based only on 1 or 2 studies. I'm not convinced there's an area of the brain that doesn't respond to creatine supplementation. And we're dealing with very small numbers. So if the one paper said that it's 2% increase in the thalamus and a 4% increase of, in cerebellum, I don't know if I believe that yet. Based on the one study, it's really premature. It's a great question. One of my colleagues in England right now is doing the 2 types of studies we desperately need. That one and the dose response study. What happens if I give you 5 grams? What happens if I give you 10 grams, 20 grams? These types of descriptive studies are the most valuable studies, but they're almost completely unfundable because it's not exciting. It's not exotic. So we all want the answers to these questions. It's a great question. We definitely need more work on baseline differences and simple response regional questions. Thank you.
So kind of moving away from the neurological aspect of creatine, but my dad has some experience with like gastric distress with monohydrate consumption. I just wanted to know if you had any insight on like, the pathogenesis of that.
Yeah, so on the list of myths, dehydration, kidney dysfunction, muscle dysfunction, GI distress is on that list. And I don't mean that he doesn't have a problem. I mean, if you think the entire room is going to have explosive diarrhea from taking creatine, that's not happening. No one's ever showed that. It's not in the literature. But if you tell me you know someone who creatine monohydrate bothers their stomach, gives them some distress, I believe you. Okay? There are individual differences, individual responses. So I would say titrate the dose. Does your dad need 5 grams per day, or can he get by with 3? And then I would look at different food combinations. For me, most of the time creatine winds up in a Greek yogurt. Right? Post-workout, whatever, a scoop, half a scoop. Doesn't have to be the same thing every day because it's stuck in your muscles for like 6 weeks. Stir it up and it disappears. And some people report improvements combining it with a larger meal, or in particular something like yogurt if they can tolerate it. I think sometimes we're taking it on an empty stomach or with really lightweight protein shake or something like that. There's a lot of dietary supplements that in a high dose can aggravate your gut a little bit. The only way around it is to titrate the dose down and start different food combinations. But if you say that's there and that's real, I 100% believe you. But as a research finding, that doesn't really exist. Does that help?
Yes.
You may have just answered this by saying how you take creatine, but I was going to ask if there is a difference regarding timing of consuming creatine, whether like pre-workout, post-workout, morning, night.
It's a great question. So we have optimal environment, right? Muscle creatine uptake increases in a hyperinsulinemic environment. So please don't inject yourself with insulin. Right? You combine creatine with a carbohydrate that gives you a hyperinsulinemic response. Do I need you to drink 400 calories of sugar with your creatine? No, most of us don't need that. You could just eat it after your biggest meal of the day, after dinner. Right? We also know that exercise increases muscle creatine uptake, so you could take it after your workout. What do most of us do after our workout? We eat. Right? So we think a lot about this, but it's kind of like just put it in your post-workout drink if there is one, or put it in your post-workout yogurt if there is one, or if that doesn't work out for you, have it in with your biggest meal of the day. That might be breakfast for some of you, it might be lunch. Some of you train in the morning, some of you train in the evening. If you could get one dose a day near exercise, that would be optimal. But your muscles love creatine, they love to absorb it, so whatever works for you. There's a lot of behavioral science in here that no one ever taught us because we're all physiologists. And it turns out that none of the stuff I say matters if no one does it. Right? So if I say, you have to put this in whey protein immediately post-exercise, people are like, no. And then I've lost them, right? So if you want to take it with your breakfast, or you want to stir it in your morning coffee, which would ruin my coffee, go ahead. Like I said, to me, Greek yogurt, creatine, it doesn't disturb the taste, it doesn't just disrupt the texture, and I'm done. I also do mix it in a protein shake, and I'm sick of yogurt. Does that work?
So obviously, creatine supplementation, very popular. But with, as with any supplementation, there's so many different supplements on the market. There's also adulteration, right, of all kinds of different supplements and a very lackadaisical regulation, right, of the industry, right. So for individuals or athletes, right, people wanting to supplement with creatine, especially with creatine monohydrate, is there a specific brand or manufacturer that you would recommend?
So it's a great question, and I'll remind you that I'm on the science advisory board for Alschem, who manufactures creatine. So anything I say now is going to look bad. But speaking broadly about dietary supplements, there's a couple different issues. One is contamination at a level that could harm any of us. Right? We see that most with herbal supplements, which are very hard to control. So we see toxic levels of mercury and lead in lower quality products. What happens, not more often, but what is a different circumstance for those of you who are going to go work with elite athletes, drug-tested athletes, there could be the level of a banned substance in your supplement that is not harmful, and it is enough to trigger a positive drug test. Right? Then for the rest of your life, when you Google that athlete's name, it says doping scandal. It's a big deal if you get a positive drug test because you took a dietary supplement that was contaminated. I've been to Alschem, I've been to their facility in Germany speaking just about creatine. I know the purity of the product, I know what else they manufacture in the facility. There's no way there's any cross-contamination there. But they market their creatine under the brand name CreaPure. You should know that if you went into a store online and there were 100 creatines, there are not 100 creatine manufacturers, there's like 2. Right? So you turn them all around and it'll tell you who manufactured it, even if the label you know is who's marketing it, who's selling it. So you need to know who's manufacturing it and call them up and demand a certificate of analysis. Go ahead, do it. If someone says, no, we like to keep that to ourselves, go get a different supplement company. All right, with Alschem with CreaPure, I can get a certificate of analysis, and I've been funded by NIH. I have to prove to them that the supplement I'm studying is the supplement I say I'm studying, and that requires a certificate of analysis or your own testing. But it's a bit like the wild, wild west with supplements. Like I said, herbs are the craziest in terms of heavy metal contamination, but it's tough now because you go to the store and you buy what? Orange juice that's calcium fortified, you buy breakfast bars that are whey protein fortified. Those are all manufactured in facilities that may or may not have good manufacturing standards. For most of us, low-level cross-contamination doesn't matter. For elite drug-tested athletes, it's a big deal what you put in your body. So you're probably going to want to go with a manufacturer, speaking generally, that does second-party testing, that has a certificate of approval of that lot number and that product is tested. There's some good research in this area on where they've looked at, they actually have an app for athletes. So you'll go whey protein and it'll list the ones that are NSF certified or the ones that are certified, not contaminated with anything. And you know, those databases are updated, and they have reduced inadvertent positive drug tests, I think 0 in Australia the last time I checked, which is quite fantastic because, you know, if you're under the impression that the only supplements that are contaminated are the ones with cool names like Jack 3D, it's not. You can go buy vitamin C and have it contaminated with an anabolic steroid hormone. Not enough to maybe harm you, but enough to trigger a positive drug test. So definitely buyer beware, but best advice, demand a certificate of analysis. Great question. Other questions? Ready to go home? I appreciate your time. Thanks, everybody.
All right, guys, thanks for coming. Huge thank you to our speakers. Thanks for coming today. We really All right, guys, we're gonna get started with the next session. Can everyone hear me? Mike, good? Okay. All right, so our next speaker today is John Matos. He is a certified strength and conditioning coach at Allegheny Health Network. And today he'll be speaking to us about warm-ups prior to strength training.
Thank you. Yeah, kind of like she said, my name is John Matos. Spelled J-A-N, throw some people off, it's pronounced John. Super happy to be here. I love this profession, a lot to learn. And just, it's super interesting. So, presentation today is warm-up and activation exercises prior to strength training. So a little bit about myself before we get rolling here. I earned my undergraduate degree at Indiana University of Pennsylvania. During that time, I was a personal trainer as well. Graduated during the COVID year, so didn't really walk across the stage. It was just a slideshow that I just saw my photo on. A little bit discouraging. Post-graduation, I went back home, got a job at a local gym called More Gains Fitness.
I was the manager and a personal trainer there as well. Spent about a year and a half there. During that time, I realized that I wanted to do more. I wanted to see how far I could go. One of my mentors at the time said that it's easy to go down, but it's hard to go up. So try to get as high as you can because it's super easy to come down. Kind of took that to heart and decided I wanted to go the route of more schooling. So I reached out to some teachers, decided I wanted to continue my education, and applied to IUP for graduate school. Was offered a graduate assistant position, gladly accepted it. That was a year-long program with an internship included. Was super pumped about the internship. Didn't get to do an internship during my undergraduate degree. Everything was shut down, so we just did it through Zoom. So for my internship, I decided to do it at Robert Morris University under the head at the time, which was Coach Day. He's now the head at IUP. Just kind of cool how things just correlate there. It was a grind. I was waking up at like 2, 3 a.m. driving from Indiana all the way to Moon there. Did that for about 3 months. Didn't really have any plans post-graduation. Was just going to apply to some jobs and see what I could get. Luckily, some things kind of worked out to where there was a position open at Robert Morris. Coach Day offered me the position. I gladly accepted it. Didn't have any other options or plans. Then I was the assistant strength and conditioning coach for Robert Morris. During that time, I was in charge of cheer, softball, football, men's lacrosse, women's volleyball, so just a ton of sports. It is a D1 school, but it's almost has lower level resources. So again, a lot of long days, Monday to Monday, especially during football season, we would lift Sunday, and then we would be right back into it Monday. So a lot of long days. Kind of realized when I have a family, I don't know how this is going to be sustainable. Started looking towards other options, and Allegheny Health Network just happened to build a new facility right down the road, so I applied to it. Some of these photos here are just some clients of ours. Bottom left, that's Albert Dequa. This facility is also home to the Riverhounds, so we train them as well. It's a pro soccer team. It's not MLS, but it's USL. And he had a great season last year. He was the USL MVP, Golden Boot. We also had Defender of the Year and Coach of the Year and our head coach. Great season, just we couldn't finish it out. Ended up losing first round in a shocker. That wasn't supposed to happen. This other photo is Cole Young. He's one of our MLB guys. Straight out of high school, he's in AAA, just working his way up. This photo is just some of the PTs, and then this is my significant other and our 7-month-old son. So new dad, a lot of cool experiences, getting peed on, pooped on, all that fun stuff. But yeah. So this is where I work. Super cool facility. We have 2 outdoor FIFA regulated turf fields, and then 1 indoor FIFA regulated turf field. This is great. We can do our plyos, our speed work out there, sled work, all that sorts of stuff. With this being a medical facility, we get a lot of cool toys at our gym that just didn't have access to in other places. So we have our Boost treadmill, valve force plates, Nord boards, VO2 testing, Kaiser equipment, which is run off of PSI, not pounds, and then just traditional weightlifting stuff. In the back, we have the saunas, Nordatec recovery station, nutrition room, so it's really cool. When they were building this, they were trying to make it an all-in-one facility, so we have doctor's offices upstairs. Downstairs, we have our MRI tech, occupational therapist, concussion specialist, and then our physical therapist. We work very closely with the physical therapist. So our clientele is everyone from little kids to high school athletes, middle school athletes, oncology patients, elderly population, and just general population, MLB, and obviously the Riverhounds as well. So super cool facility with a lot of gizmos, gadgets, and I really enjoy working here. So warm up. So a lot of people don't like to do the warm up. It's just can be tedious, but it's super important to do. As a sports performance coach, it's arguable that my main objective is injury prevention. And we can help to kind of mitigate any injuries through the use of a proper warm-up. An athlete is no good to their team if they're injured, especially at the pro level. This is their job, so we want to make sure that they're healthy and that they're able to play. As well as the general population, they're no use to their job, to their family, to their kids if they're injured. So injury prevention is arguably one of the main components that we're looking to do in a proper warm-up. So improved performance, proper warm-up can give us the ability for improved performance. Mental preparation, I believe mental preparation is a big part of the warm-up. A lot of athletes, especially the Hound season, it's long. Hopefully we go till late November, and then it just becomes tedious. It's their job. So this just kind of lets them flip the switch and to start getting ready to do the activities of the day. And then our general population, individuals, some of them are higher up in their business, so doing a warm-up lets them kind of unpack the baggage of the day and just flip the switch to start going towards activity. Enhanced range of motion. So a proper warm-up, we want to try to enhance range of motion in a way that the client can control. We do that through dynamic stretching, mobility exercises, and just hoping to improve some ROM. Activation of muscles. Activation is just a fancy word for just bringing attention to a muscle, learning how to contract it properly, and learning how to use it. So that can kind of help us in day-to-day life as well as just go on into our main blocks of exercises. So gradual increase in intensity. We want to gradually increase the intensity of the exercise. We don't want to come in and go 100%. We want to slowly build up to that. So a little bit of overlap from the last presentation. Joint by joint theory, Mike Boyle, great cook, I believe came up with this. So from the bottom up, we want the ankle to be mobile, knee to be stable, hip to be mobile, lumbar spine to be stable, thoracic spine to be mobile, and cervical spine to be stable. So this is just important when we're looking at our warm-up, especially sometimes when we're activating muscles, we're looking to stabilize certain areas so that we don't have compensatory movement patterns above and below the chain. If we look here, it looks like the thoracic spine in this diagram is the weak link. So we don't want any kinetic leaks. We don't want any power to go away kind of when we're doing our movements. So usually when you come into one of our facilities, you'll come in, you'll hit the bike, and then we'll do a soft tissue mobilization. So with soft tissue mobilization, foam roll, cheat man's massage, whatever you want to call it, we're looking to increase some blood flow with the possibility of improving mobility and flexibility and possibly enhancing muscle activation. Kind of how they stated in the previous slide, the science is leaning towards more of this. This is just a sensory component where we're just going over this muscle and it lets the muscle relax a little bit. The second thing that you'll do after you foam roll is you'll activate muscles. Usually the muscles we're activating are smaller muscles that are often that we don't use. We like to do this during the warm-up because they're fresh. We don't want this later in the warm-up to where they might just skip it. So we like to throw our activations in the beginning blocks there. So we're just targeting specific muscles that, muscle groups that are usually underactive. So targeting these muscle groups helps to enhance their engagement and recruitment during the main workout. So this possibly can aid in improving performance, like we talked about the kinetic leaks. If an area is weak or underutilized, it could possibly cause some kinetic leaks. So areas such as the glutes, the scaps, and the core are three of the main areas that we like to activate. So going off of the activations here, the glutes, made up of glute max, glute med, glute minimus, is one of the areas that we look to activate. A lot of general population and individuals that we see, their glutes aren't firing properly. They don't know how to use it. When they squat, they're very knee dominant. So we want to get their glutes firing and learn how to use them. So hip extension, hip abduction, hip external rotation, spinal stability, power generation are all just some components that the glutes do. So glute, when we talk about our glute activations, the main thing that we're working on is the glute med. Can cause some hip pain. Poor hip stability and control can lead to stress in the hip. can cause some knee pain. If our glute med is weak, it can cause our valgus knee cave, so we can put a little bit more stress on the joint or the ligaments inside the knee. With that being said, valgus knee cave in a controlled environment, we want to make sure that we're cueing out of it. We will see some valgus knee cave, especially in more advanced athletes on the field. In Olympic weightlifting, towards their higher end lifts, we might see some of it. But for general population, for weaker athletes, we want to make sure that we're cueing out of it. Lower back pain. I would say lower back pain is one of the main things that people come to the PT side to see. So, lower back pain, I would say knee pain and shoulder pain are probably our top three that we see. Shin splints, plantar fasciitis. So weakness in the glute med can cause that leg to rotate inward, possibly causing some shin splints, some plantar fasciitis as well, and just the kinetic leak. If our knees are caving in, if we don't have that control, we're not going to be able to generate as much power off the ground as we would like. It's going to mess up the chain as we go up. Example exercises, there's a ton of exercises to choose from. It just depends on the individual, who they are, what stage they're at. So clamshells, ankle bands, glute bridges, donkey kicks are just a couple examples of a plethora of exercises that we can do. Scapular activation. So scapular activation is kind of misleading a little bit. The scapula is a bone. We're mainly looking to activate the muscles around it, the traps, the delts, the rhomboids, the rotator cuff, to help stabilize the scapula and get it moving properly. So scapular weakness. Poor posture is probably one of the main components that we see, this kyphotic posture. Everything's out in front of us, so we want to help pull everything back, work the muscles that we can't see, and just help in aiding kind of that avoidance of back pain as well as upper neck pain. We don't want to be in this position. A lot of what we do is forward. We work our rear muscles, so we want to work everything in the back that we can't see. Can cause some scapular dyskinesis, so weakness in the scapular stabilizers can cause the shoulder blade to move funky, not exactly go against the rib cage as we would like. Increased risk of shoulder injuries. These are all possibilities. This is over years that these can happen. Rotator cuff tears, shoulder impingement, labral tears. If you round your shoulders for a brief period of time, it won't cause issues, but this is over years. Example exercises, YTIW, 4-position tubing, scapular push-ups, banded Ys, just depends on the individual. So core activation. We like to think of the core like a pillar. So everything from the shoulders to the hips, we like to consider the core. When we're training the core, we will add some isolation exercises, but we mainly like to think of it as a structural component. So a structure that the arms and legs can pull off of, it's less likely to generate force. When we think of a squat, a deadlift, it's more of just acting as a brace to let us move. So core weakness is kind of a popular term. We hear it, oh, your core is weak, your core is weak. It is overstated, but it is important to work on the core. So lower back pain, if the core is weak, poor posture, spinal instability can kind of aid in that back pain. Reduced balance and stability, especially in our older population, we want to make sure that the core is strong enough that they can maintain proper balance. Usually in the older population, a fall can kind of cascade into a bad road, so we want to make sure that their core is strong enough to keep their balance there. Impair athletic performance, kind of like we see when the core is weak or when muscles are weak, it's just going to cause compensatory movement patterns up and down the chain, and just cause some kinetic leaks, some power leaks in there. So some example exercises, we have ground core, plank, side plank, hollow hold, Russian twist, landmine rotation. There's a ton of these that we can pick from. So usually when you come in, we'll bike, we'll foam roll, we'll do our activations. The next thing we'll do is some mobility. So mobility is super important. We want to try to enhance range of motion. Increasing range of motion in a way that somebody can control can help them get into better positions. So we want to make sure that we're getting them into good positions to reduce the risk of injury, and just so they can perform the movement better. Injury prevention. So again, compensatory movement patterns. This can cause imbalances, overuse injuries. So we want to make sure that we're training out of that. Optimized performance. This allows for more efficient force production, power generation. Again, going back to that kinetic chain, we want the whole chain to be strong. CNS prep, we usually end our warm-up with some sort of something to get us firing, something to get us excited. So we want to prime the nervous system so we can perform optimally. We usually do this with explosive movements, our plyometrics, med ball throws, box jumps. We have a Dynavision at our facility. It's just a big square that lights kind of pop up, and we can press those. So it's good for our older population that can still get some of that reactivity in there, and kind of just work the brain as well. So some examples. These are generic examples. There's multiple ways to skin a cat. I've seen people do this in a large variety of different ways. So we look at the left side here. Possible day could look like we warm up, bike, foam roll, then we do a glute activation, ankle bands, essentially just two ankle bands, one above the knee, one by the ankles, and we're just focusing on the glute med, standing clamshells, lateral walks, etc. Scap activation, essentially just a band pull apart in 4 different positions. Core activation is just working the core 360 as well as hitting the glutes there. Movement and mobility, since the main lift we're doing is a barbell front squat, we might do something like a reboot stretch or a squat to extend, where we're grooving that pattern in, and we might add some T-rotation to where we're moving the spine. Speed and agility, we might do something like a rudimentary jump series. It just depends on the client. And then we do a barbell front squat. So this is when you can really start to tailor it towards the individual. So if an individual comes and we're doing a front squat, and their lats are tight, they're having trouble getting into that front rack position, we might throw some more lat mobility in there. We might, in the warm-up, we might hit the lats with the lax ball, just to kind of help loosen that up. If their ankles are tight, we might do some ankle mobility in there as well. On this right side, main movement of the day might be a Swiss bar bench press. So we'll start off with a lower tier exercise like a glute clam. The scap activation, we do something more to activate the scaps, just to really get that fire and get everything pulling backwards. And then for our core activation, anti-rotation, essentially just a pal-off press. Movement mobility, we might do a PVC prayer stretch, getting some thoracic extension, and then med ball exercise or power work, which is essentially just a series of med ball drills. And then we go into our Swiss bar bench press. Now this is just a framework. I've done it before where maybe we're going to a heavy set of Swiss bar bench press and we throw a band pull apart as our active rest, or we throw a mobility exercise as our active rest. Same with the barbell front squat. Maybe we do a lat lunge stretch as our active kind of rest, and maybe we do clamshells there. Depends who the athlete is, depends what our goals are and what we're trying to do. So, any questions before we get into the fun part? You guys ready? Okay. This is just a works cited page. I want to do a dynamic warm-up. Now, if anyone has any issues as far as like, my knee bothers me, don't feel like you have to do any of these movements, okay? Just kind of stand aside and just wait for this till we get into the next movement, okay? So let's come out to the gym floor. We'll get into let's do lines of 7 and see how that looks, okay? First group, let's continue to move forward a little bit, and let's follow behind a little bit. So I want you guys to extend the arms out. You move around, make sure you don't partner. If you do, slide down. Can everyone see me? So the first thing we're going to do is full weight jack. So essentially what this is just a jumping jack in 3 positions. First one is just a normal jumping jack. We're going to do 10 each. Normally we do this like on a wrist or this is just the arm. So let's do it. Jumping jacks. 10 of them. Okay. Next we're going to do a seal jack. So we'll be here, come in, come out. 10 of those as well. That's it. Next we're going to do a running jack. So we'll be here. And essentially what we're going to do is we're going to extend out. And we'll switch. So we'll be here. 10 of those as well. Let's do it. Okay, next thing we're going to do is a shift squat. We'll be here. Legs are a little bit wider than shoulder width. We're going to sink to one side and sink to the other. 5 each. Make sure we're sitting back once there's a chair behind us. Good. Yep. Very good. So, next thing that we'll do is windmill. So with the windmill, same thing. Feet a little bit wider than shoulder width. We'll go to touch 1 foot, but I want the eyes to look upwards. So we'll be here, and we'll switch to the other side. Okay? 5 each side. Yep, very good. Okay. Next thing that we're going to do is try to do uncomfortable. If we need to adjust, we will. We're going to go into a side plank position. So when we do this, if you need to, go on your knees, or we can just come to the side here. So we're holding this position about 10 seconds. I'll let you know when to switch to this. Let's do it. Sweet. Switch to the other side. So with these movements, continue to challenge it and progress. Bottom leg, you can drive it forward. You can have some abduction. Just continue to challenge it. Good. Let's go into switch position here. The next thing we're going to do is 5 pound down, and then we're going to go right on your stomach. So we'll be here. 1, 2, 3, 4, 5, 7, 8. Okay? So ready? 5, 4, 3, 2, 1, and break. So next thing we're going to do, we want to just activate the long weight of the delts in the back there. So hopefully you guys can see this. We're going to be lying on the ground. We'll do 10 eyes, 10 Ys, 10 Ts, and then we'll go from there. Okay? So make sure your traps aren't up by the ears, that we're keeping them down. We're pinching the shoulder blades together, and then we're lifting them up. I know it might be a little bit uncomfortable on the floor, but let's do it. 10 eyes, 10 Ys, and then 10 Ts. Very good. Yep. So once we're done with those, the next thing we're going to do is bows. So we're still going to be on our stomach, but we'll just punch in the air, just like this. Okay? Let's do it. 10 of those, 5 each. Good. Yep, exactly. Once we're done there, blocks are next. So arms will be above, we'll come to the glutes and then back up. So we'll be in this position. 10 of those. Very good. Sweet. So next thing we're going to do is go into the Spider-Man stretch. World's greatest stretch, not whatever you want to call it. So one foot is going to be up, the back foot is going to be extended out. So once we get to that position, what we're going to do here is we're going to try to work this elbow down towards the foot. So we'll be here, we're going to come up, extend this front leg, extend the back leg. Okay? So back leg should be straight. Awesome. I see you. So we're going to do that 5 times. No, you're good. Very good. So once we hit our 5, we're going to switch sides. Go to the other side. Very good. Yep. Nice. Okay. Next thing, you can stay in this position. Next thing we're going to do is we're going to open up and back down. Open up and back down. 3 on one side, 3 on the other. So this is usually our athlete prep, we call it. Some of the general population, we usually will just do some sort of banded activation. It won't be as extensive as this. So next position, how's everyone's knees? Good? Nice. Next will be a quadruped position, all 4. What we're going to do is 10 forward circles, 10 reverse circles. When we're doing that, try to keep the spine flat, so the knee should be under the hip, and then just thinking there's a hurdle beside you, really trying to mobilize that. Okay? Let's do it. 10 now. Nice. Yep. 10 forward, 10 backwards, and just switch sides. Very good. Yep. Next thing we'll do after that. Next what we're going to do is just donkey kick. So we'll be here, we're going to drive that toe down, and drive that heel straight up into the sky. We're going to do 8 of those. 8 one way or 8 the other way. Yep. You see how we're kind of working everything? We can progress this by having a band around the laces and having to push against some resistance. This is how we can just continue to progress it. The next thing I'm going to do is a hand curl. So we'll be in this position. We'll come up to this 90 degrees and we'll curl here. 10 there as well. This is a warm-up. So yes, there are exercises, but it's also stretches as well. So we kind of like to do both. Very good. Yep. Next thing I'm going to do is we'll lie on our back. We'll go into a seated position, so we sit on the ground. So, next thing we're going to do is essentially just a V-sit. So we'll be in and out. 10 minutes. when we do this warm-up, like I kind of said, this is usually for athletes, a little bit more advanced population. But we're kind of working everything. So we start from the ground up, working with core, activating the muscles, hitting everything. The next thing that we're going to do, twist. So we'll be here, Russian twist. 20 total, 10 on one side, 10 on the other. Very good. So yes, they are exercises. We like to look at it as a warm-up is just essentially movement. So we're looking to hit certain points, hit certain muscles. We want to make sure that the body is doing what we want. Next thing that we'll do is a toe touch. We'll be on our back. 10 there. So at this portion, we would stand up, so we're on our feet, and we do something more cycle. So getting into our jumps. So we can stand up here. And then we do something like doing the feet, but we're just doing the feet fast, kind of as fast as we can in each spot. Let's do it. Yep. And repeat. So next we do something like jump off. So we just continue to jump similar to the Let's do it. Let's do our jumps. Yep. This is how we did it in the collegiate setting. This is how we do it at college as well. So usually in a team setting, this is how we do it. I want to break off into some groups and do some lower tier activation exercises. Like say a grandma comes in or somebody that's just rehabbing, getting back into exercise, and we'll do some like lower tier ones. Okay, so let me grab my bag here. Was the workout, huh? Happy Saturday. Yeah. Let's grab these ones. One and one. So let's put that right foot in. So we'll step into it. Put that right foot. The blue band is going to be one with a little more resistance. You can have it. Very good. So this next is just going to activate the blue band. So right squat position will be in and out and in. Okay? This is another tier one. Like I said, smaller child, elderly population, somebody who's coming from rehab. We're not going to do that what we did. We'll come in and still do new activations, scap activations, and cool activations. going to go into a side plank position. So this is, you could argue, is one of the easiest ones. So we'll lie down on the ground on our side. And then from here, say somebody can't support themselves in a side plank, we can just start here. Continue to go this. After a couple of weeks, we can kind of progress it to be out in the side plank position. So let's go up on the side plank. If you can't, let's just lay behind it. Let's just lay down. Okay? Most of us should be good in the side plank position. When we do this, the bottom knee should be on the ground. So it is like a modified side plank. The bottom knee stays on the ground. We're opening the band up, staying apart. The legs should be slightly bent. Yep. So this is called a clamshell. We're kind of mimicking what clamshell looks like. We'll do 10 one way, 10 the other. Yep. Exactly. Yep. The knee should be bent correctly. Somebody comes in, this is what we can start with. We can progress to where they're on this side. Take that band off. So, progression on that. Say you're doing well. Weeks of catch. We can go into a blue star. So we're here, and we can come up, back down. Come up, back down. Let's just do 5. Okay, got it. 25. That also means the same thing. So, for the core portion, similar to what we did earlier, we could just modify it. So we could be in a V-sit position, we could do our Russian twist, we could do our reach-ups like we did. Depends on the individual. So let's just do a modified core series. So let's do our reach-ups. But we're just going to do them straight up in the air. This is not a crunch, it's just a short weight off the ground. So we'll come up, back down. Let's just do 10. Yep. So most individuals don't have issues with this. And then next, we could go into our Russian twist. We don't have to do what we already did. We could go into our Russian twist, and then lastly on this, we could just do blue bridge. So we could be in just a normal blue bridge position. Come up and back down. This is modified of our ground force. Very good. Just feel that forward, feel that forward, super good. Next, we stand up. Let's put a band around the wrist. So, let's do our second activation here. Now, the band's kind of determine how far your intensity the exercise can be. So, keeping the elbows tight, almost like you're moving the sides, keep them open, they close, and twist. Very good. So with this, we can go and do something like a band pull part as our side activation. We can do an X-band pull part. We can do regular. This depends on who the athlete is in terms of exercise selection. It's super important to look at the athlete. What do they need? When you're in a group setting, it's hard to individualize it. In a private setting, we can really focus on the athlete. That's the most determined to be on. So, how's that feel? Do you feel warm? It's hot. It's hot. Feel good? guys. I'll collect the bands here. Actually, do you want to collect the blue ones? I'll collect the green ones, and you want to collect the yellow? So blue will be with my man right here. Yep.
All right, guys. As we're wrapping up, go ahead and grab your stuff. Our next session is going to be in the IM weight room. And then after that will be lunch and STEM, so we're not going to come back here. So we have about 15 minutes or so before we need to be over in the weight room. So do what you need to do, and then meet us over there.
What's up, man? Good, how are you?
That's awesome.
She runs the whole massage department. Growing this up. Have you got, I guess, one of the grub seed? Aaron Colberry?
He was, I think, before you guys, or before. Yeah, because he's 4 years older than me. Yeah, so I think he would have been graduated before you came in. He's biology. But.
It's been a good area. It's just a tough in this area because of the way the health systems work, UPMC age, and with us being independent, they really try to like elbow you out of the system. Now that has been changing a little bit more recently. Still provides some challenges, but we've been able to work around it, create our own referral sources. But every group we work with is we're always very happy with. You get the whole gauntlet, work ethics and all that. Generally, groups you guys are all of us very, I would say, culturally aligned. Yeah, good.
All right, guys. Welcome to the 2024 Grove City Exercise Science Symposium. Thank you guys for coming out on a Saturday morning. Hope you guys got some coffee, energy drink, or and a pamphlet out front. Just to let y'all know, in case you didn't see, we have 3 in-person talks. We'll be in this area in the IM weight room until lunch, and then we'll take a break for lunch. There'll be 2 lectures in the afternoon. We encourage y'all to stay for the whole thing. We have some really good speakers and topics here today. We're very excited about it. Our first speaker is Dr. Justin Scott from Teresa Gotham. Teresa's a Grove City grad. Dr. Justin owns the Next Level Spinal Sport practice down in Wexford. They do chiropractic training, assessment, a host of other things that they will talk about during the talk here. Dr. Justin has been doing this for quite a while now. He's run a practice in Wexford with multiple locations. He's a great guy to work for. I had an internship there. I know a couple of you guys do coming up as well. If you're ever looking for an internship and you're looking into rehab care and treatment for athletes and for high-end athletes and weekend warriors and those kinds of things, please look at Next Level Spinal Sport for internships. I'll turn it over now to Dr. Justin and Teresa.
Thanks, JD. Can you guys hear me all right? Up there, no problem. I won't use the mic. Okay. First of all, I just want to thank you for having me today. We've had a lot of Grove City interns over the years. We always have a very positive experience with our Grove City grads, so we're happy to be able to work together a little bit more. Like JD said, I own Next Level Spine and Sports Injury Center. We have offices in Cranberry, Wexford, Mount Lebanon, and the Strip District, so 4 offices around Pittsburgh. We're a multidisciplinary office, so we have sports chiropractic, physical therapy, massage therapy, and exercise physiology. The general thesis of the practice is that we take the best of all different approaches towards physical medicine and rehabilitation and try to bring them all together. When patients or people, athletes have pain, there's always this conflict of where do I go, where do I start, where's the best place for me to make my first appointment. And with everybody segmented, that gets challenging. And so bringing all those different types of providers together, it gives us the opportunity to treat anybody who has any type of physical pain. And it also, I think, elevates the quality of our providers. Working in a multidisciplinary setting, you have PTs, working with chiros, working with massage therapists, there's a lot of good discussion. We all know that our approaches might be slightly different, but our goal is the same, to get the patient or the athlete back to doing what they enjoy. And so we are all synergistic in that fashion. So today we're going to talk about the intersection between movement assessment and soft tissue mobilization. So the background to this, I think, is important to understand what type of pain and injury you might be treating if you're talking about a clinical setting. So whenever we think of pain or injury, most often we're thinking about something that's traumatic. You kind of have stuck in your head a tackle, a fall, an ACL tear, something like that. But the vast majority of the types of pain and injury that you're going to see in a clinical outpatient setting are not going to be those traumatic type injuries. They're more going to be in this category of cumulative trauma, repetitive use. All that this means is you have a throwing athlete who's repetitively doing something with their arm. The same tissues are going under a repetitive load over and over and over and over and over again. Those tissues eventually start to wear out, get irritated, and that's how you end up with a sprain strain, tendinosis, muscle tearing, things like that. You're going to find that the minority of the injuries that you see are going to be from a traumatic event. It's this cumulative trauma, repetitive use type issue that seems to be most common. What happens here is you have little micro traumas that build up into tissue over time. When you're in this phase here, if we look at the y-axis as being muscle irritation and the x-axis as being time, you're going to have a period of time where you're developing muscle irritation, but you're not really feeling anything. That's subclinical, we'll call it subclinical problem. Once you reach a certain terminal point, and this is different on everybody, you break through that line, you'll start to feel pain or you'll start to feel injury. This paradigm of care will play a role in how we discuss what the most appropriate, efficient way is to get it to alleviate. These repetitive uses or repetitive actions can be anything from repetitively unloading the laundry machine to deadlifting 500 pounds. You're not really going to treat an athlete or somebody who is a homemaker or somebody who works in a factory any differently. They all go under repetitive stress, and so they really can be treated within the same paradigm. At our office, we have everything from, we're the Pittsburgh Penguins team chiropractors, so we work with the Pittsburgh Penguins, and we work with everyday people from the community, high school athletes, to elderly population that, like I said, has trouble getting things out of the laundry machine. This approach, we feel, captures that whole paradigm of all types of patient classes. So if we look at our whole topic of the discussion today being the intersection between movement assessment and soft tissue mobilization, those are two pieces to the treatment paradigm that we don't feel like we can get adequate results if either one of them is used in isolation. So in this example on the left, it would be a representation of if you would just use soft tissue intervention, but you were never actually trying to assess or correct any type of movement problem. You'd have your muscle irritation that would build up, you'd break through the line that the patient would start feeling pain. You'd apply your soft tissue treatment to that localized problem, that localized area that they're having issue, and that would decrease their pain likely and help to heal that tissue. But that underlying movement problem is still going to be there. So they're going to go back to their activity, they're going to deadlift again, they're going to throw again, they're going to get laundry out of the machine again, and it's gradually going to build back up and you're going to be right where you were. So you're going to see this rebounding ping pong effect. I feel good, I get treated, I feel better, I do my activity again, I have pain again. You're going to see this case over and over and over. But a lot of times the reason for that is the approach is singular, it's not bilateral in that capacity. In a similar scenario, if you're just doing movement correction and you're not addressing that soft tissue component of things, you're going to have the soft tissue irritation build up, you're going to break through the plane. Once you get above that plane, you're going to correct that person's movement pattern. That will get you to the same ending place over a long enough period of time. If I change how that person is moving, I'll stop the irritation, that muscle irritation will start to go down. but it'll go down much more gradually over a longer period of time rather than that acute drop that we see over there. The problem with this is the reality of life. Patients need to feel better to be compliant with care. If I'm telling you to do X, Y, or Z for your shoulder and you're not feeling better, and a week goes by, and 2 weeks go by, and 3 weeks go by, and you're still not feeling better, how likely are you to continue to comply with my treatment approach? Probably not very likely. You're not going to buy in, you're not going to do your home exercises and all of that. So that curve just takes too much time. So if we can give them some relief, accelerate the healing process while we simultaneously correct the movement dysfunction, not only do we get efficient outcomes, but we get long-term, reproducible, standing outcomes. There are many different approaches that can fit within what I just described, right? So we have a movement assessment combined with soft tissue mobilization. There are plenty of different movement assessments that you can use, and it's our opinion that there's not necessarily one absolutely perfect path to go down. What you're trying to achieve is a reproducible system of testing so that you can have inter-practitioner communication about what you're finding with the patient, and that you can also show and demonstrate what type of movement dysfunction that patient has, so you can demonstrate it to them, increase patient buy-in, understanding of their problem. We put some examples here, but you can really assess in any way that you want. For soft tissue mobilization, it's the same kind of approach. There's active release technique, which is something we're going to talk about today. There's IASTM, which is instrument-assisted soft tissue mobilization, most commonly known as like Rawson technique. You have dry needling, deep tissue massage, trigger point neuromuscular, cupping. These are all just different ways of impacting the soft tissue. We'll break this out a little bit further and talk about each one of those. So with our approach, I think it's really important that you understand that we're not saying that this approach is absolute. This is not the only way to do it. It's not the only way to get to an outcome. These are just the pathways that we have chosen that we feel are most efficient. But you could really plug any of those approaches that you saw on the last slide into this paradigm. We have chosen this system for a few reasons. That it creates quality outcomes, it facilitates inter-practitioner communication like we talked about, and it helps with patient buy-in because they understand their problem and we can show them and test, retest as far as how they're improving. So our movement assessment that we have chosen is the selective functional movement assessment, and then the soft tissue technique that we're going to talk about today, even though we use other modalities, is active release technique. So let's dig into those a little further. So if we're looking at the selective functional movement assessment, so this is like a cousin of the FMS, the functional movement system. I know that there's been a lot of studies that have come out that when they tried to connect a injury risk profile to the outcomes of a functional movement screen, there was very poor correlation. We don't disagree with that, nor do we think that that's an impacting factor to why we use it. The FMS is a branch off of, or the SFMA is a branch off of the SFMA, or the FMS. The FMS basically tells you that there is a problem in some region, but it doesn't necessarily break out and tell you what that problem is or what might be causing it. The SFMA takes that one step further, and we'll talk about that. It functions off of this principle of regional interdependence, that I don't know if you guys have heard of like the joint-by-joint approach, but this basic concept is the body functions in alternating segments of stability and mobility. So if I start at my foot is stable. I'm supposed to have a stable platform with the ground. My ankle is a very mobile joint, almost 360 degrees. It has a lot of movement to it. I move on to my knee. It's a hinge joint. It's largely supposed to be stable. It's not supposed to have 360 degrees of motion. My hip is largely mobile, right? That has a lot of motion. Then you're onto your core, which is supposed to be stable. Thoracic spine, which is supposed to be mobile. Scapulothoracic, your shoulder blade articulation with your mid-back, which should be mobile, stable. Glenohumeral joint, we're back to a 360-degree joint again. That should be mobile. The elbow is a hinge joint, and then the wrist is a mobile joint. The hand should be stable. So the body very inherently is organized in that fashion. If you start to disrupt that sequencing, that's when we start to see problems. I can't raise my arm enough overhead, but then I'm still putting load on it. So what's going to happen? I'm going to start to wear out and impinge the anterior part of my shoulder. So that's kind of the intersection of how these connect. What we like about the selective functional movement assessment is the fact that it takes this one step further. It doesn't just say that there's some sort of problem in the shoulder. It takes it to the point where we're going to divide that out and determine whether we think that's a tissue extensibility dysfunction, which is TED on here. That basically is a fancy way to say that it's tight, that the tissues need to move farther, versus an SMCD, which is a stability motor control dysfunction. So is the reason that I can't raise my arm overhead because the local tissues are too tight? Or is it because the general biomechanics of my shoulder are such that I'm not moving my shoulder blade in the right way and I'm not stabilizing my rotator cuff in the right way, that I can achieve the end range of my actual motion? When we break out here and do some of this testing that you guys can try, you'll be able to see tangibly this difference. You're going to see some people that just have a tightness problem, then you're going to see some people who have an SMCD or stability motor control problem. The reason that's in red there, it is massively important that we discriminate between those two. If you have a problem that is a tightness problem and you're just attacking it with stability, you're not going to get the outcome you want, and vice versa. So if we just say, hey, there's a dysfunctional movement pattern in the shoulder, but we don't know what it is, it makes our outcomes pretty limited. Moving on to soft tissue. Soft tissue is definitely a hot button topic right now. There's some debate as far as how much it works, why it works, when it should be used, all those different things. I would say that the most current science advocates for the fact that a concept of breaking up knots or releasing adhesions is not really what's going on. That's an easy way to explain it to the patient. It's easily digestible and understandable, but it's probably not the scientific explanation for what's going on. Most likely what's happening is we're creating an overload of neurological input into a structure, which is then changing how your brain is interacting with that tissue, and then it is creating a neurological reset that is decreasing the sitting tone within that muscle. So that's a much more complicated example. If you're working with a patient, it's much easier to say, oh, I'm just going to break up this knot in your back. To go into that explanation is fairly challenging, and I think that's one of the reasons that so many people in the field don't necessarily go down the road of explaining it the scientific way, is because sometimes that can be challenging. But the scientific way is another reason that it advocates for the fact that there are multiple different ways that you can achieve this, and it doesn't really matter which one you use. So whether I'm taking dry needling and I'm poking needles in the tissue, or I'm doing ART and I'm doing a compressive stretch and release technique, I'm still increasing the neurological input to that tissue, which is going to create this mechanism that we're talking about. So that's where we say with soft tissue implementation, you can use these things interchangeably. Some people really like one technique versus another. The reason that we use ART in our offices so much is a few reasons. One, it's clinically convenient. If any of you have had Graston or any of the instrument-assisted soft tissue mobilization done, they have to get directly on your skin. And so doing that in a clinical setting and being able to work on an adductor tendon or a hip flexor or something like that can just be challenging to use a tool to do that. ART is a technique that you can do over clothing and through clothing. So it's just clinically convenient. It's easier to do, and that's one of the reasons we grab it. Patients seem to like it. It feels good. I talk about patient buy-in a lot. No matter how good we are as providers, if I can't get my patient to do what I need them to do, it doesn't really matter how good I am at what I do. So if I'm doing a treatment on them that's largely uncomfortable and makes them irritated and worse, what's my buy-in? It's not going to be high. So we have to be conscious of that fact. This is something that overall feels good. And we also see the quality of outcome that we'd like to see. We see that the tissue responds in an efficient amount of time, which again aids in overall patient care, but also patient buy-in. Unfortunately with this, because of this being an undergraduate lecture and with the restrictions that can occur within some licensing, I can't necessarily teach you guys some hands-on stuff. We'll demonstrate a little bit, show you what it is, and we'll kind of break out and we'll do a little bit more hands-on when we're doing the movement assessment piece. So practical application, how would this approach, this two-tiered approach, fit in an actual clinical appointment or a visit? First thing you're going to do is get a clinical history, right? What's the background history of surgeries? How did this happen? What's the mechanism of action? All those types of things that are pretty standard. Then you're going to do what everybody would consider like a standard assessment, medical assessment process. Orthopedic exams, neurological exams, range of motion exams, those types of things to understand what the best baseline assessment at that point is. Then if you're working in an office like ours, you're then going to do a localized soft tissue assessment. So we're looking for tenderness to palpation, aberrant densities within tissue to determine which structures we believe are irritated. One big factor here is muscle testing. So if we have, say, an elbow, for example, there's a lot of different muscles that tie into that elbow. And if I have lateral elbow pain and I'm trying to determine, is this more of a wrist extensor, traditional like tennis elbow type irritation? Is it a supinator muscle sprain strain? Is it a triceps sprain strain or tendonitis? Sometimes those can be a little bit hard to weed out. And to be honest with you, orthopedic testing isn't that great, to be honest with you. So a very simple, and it almost seems too simple, and this is why I don't think people do it enough, is just muscle testing. Create muscle activation within the muscle fiber that you think might be irritated and see if that reproduces pain. So if I have you fire your wrist extensors and that doesn't hurt, but I have you fire your supinator and it does hurt, where am I going? I'm going after supinator first before I'm messing around with generically just hitting everything in that area. Same idea with the tricep extension. If I fire the tricep and that reproduces pain, I'm probably going to go after that tricep. Some of the most valuable diagnostic, treatment, impactful tools are pretty basic things, and I think a lot of times they just get looked over because they seem almost too easy. We would then move on to a movement assessment. So that's when we're going to look at a regional interdependence type of scenario. So if I have anterior shoulder pain, I'm mainly going to be looking at from the hand down to the thoracic spine. So that's going to be looking for the thoracic spine to be mobile, scapulothoracic to be stable, glenohumeral to be mobile, elbow to be stable, wrist to be mobile. Once we've identified where we think the cause of the pain is, and we know what we think the movement dysfunction is, we're going to apply whatever your chosen soft tissue treatment is. So that could be ART, Graston, dry needling, cupping, massage, whatever you want to do. And then you're going to provide focused, customized corrective exercise protocols that are geared towards not just the region of dysfunction, but what type of dysfunction there is. Is it a tissue extensibility problem, meaning do we have a tightness problem, or do we have a stability problem? A lot of times you can have a scenario where you have both present. If both are present, you're probably going to attack the TED, the tightness problem first, tissue extensibility, and then once you've freed up range of motion, then you're going to circle back and address the stability motor control problem. But that's what that would look like in a clinical setting as a workflow. So this shoulder, should we maybe bring them out? Okay. So we're going to have everybody come down. We have a table set up on the floor. If you guys can just kind of circle around the table, we'll demonstrate some stuff and then we'll break out and start to work on it. call it relatively normal. We're not concerned about a tear, a rupture, anything non-musculoskeletal, tumors, or anything like that. So we ruled all that out. Now we're at the point where we want to assess her movement, and then we'll talk about a little bit about how we treat that. So when we assess from the thoracic spine out the chain, like we just described, first step of that is going to be determining whether or not the thoracic spine is mobile, and then also whether or not it can activate the way that we need it to activate. The tricky part about the mid-back is that you can get a lot of compensated movements, so I can be compressed through my mid-back and still kind of cheat through my lower back and get my arms overhead. That doesn't mean, just because I can put my arm overhead, doesn't mean that my thoracic spine is actually mobile. So we have to very specifically force that tissue into a position where it is forced to not be able to cheat in order to see a clear vision. So Teresa's going to go kneeling on this table facing this way. She's going to sit all the way back to her heels, and then she's going to put her left elbow in front of her. When she's in this position, the hip is above 90 degrees. That starts to lock your lumbar spine into a position so that when we ask her to move, she's not going to be able to so much rotate from here. We're going to be forced to see some motion through her thoracic spine. So then she's then going to put her right arm behind her back. We're going to have her try to turn her right shoulder up, open to the ceiling as far as she can. Go ahead and bring her back down. So what we're looking for, and you can relax on this. If I look on from this position, I want to see 50 degrees of rotation. So when she did that, she had totally fine range of motion, no problem. I'm going to just pretend it can't do it. So let's say she comes into the same position and she can't move that far. I don't know whether this is a tightness problem or whether she just can't activate it. So I'm going to come in and actually push her, okay? If that difference is more than 10 degrees, we would consider that a stability problem. Meaning you're always going to have a little bit of extra end range after you finish your active end range, but you shouldn't have more than, say, a 10-degree margin of error. So if that changes more than 10 degrees, I would categorize that as, I could have her stretch her mid-back for years. It's not going to change. She has the ability to get there. It's just she doesn't have the ability to activate her tissues to get her to that place. So you can see if I didn't take this step in an assessment and I tried to improve the range of motion with her, but I approached it in the wrong manner, you can spend a lot of time taking patients down the wrong road. It isn't going to make you fall back. So in that scenario, if she tested out where she was just stuck and I couldn't take her any farther, we would give her stretching or mobilization techniques to open up her mid-back. If I was able to push her significantly farther, we would go after more scapular activation, thoracic extension activation, those types of things. Looking further, now we're going to go out to the shoulder, so she's going to lay face down on the table. They will use on both sides. So she can have it all straight arm up. When she does that a little bit, this column does not go all the way down. See that parallel here or above here. I'm going to stabilize her mid-back so she can cheat, and I'm going to press this out. So she maybe gets about 10 degrees of change. It's not, so I wouldn't consider this significant enough that I would categorize her as a stability or control problem. She's probably tight and needs to stretch that shoulder. Just so you guys can see this elbow straight, thumb up, straight up your shoulder plus. Elbow's actually a little bit better than the other side, but really better. Now we're not going away. About maybe 10%, not significant. So if this was a real case, I would guess that the shoulder pain is on the right side, and we would focus in on some shoulder flexion mobility. So that's just checking flexion. We have to check supplementation. Here, that gets back to the ceiling, do the same thing. And we're going to be conscious of like shoulder cheating and things like that. You're going to have to be, as you're doing this in a real clinical setting, with the movement, for our demonstration focus. I'll go straight and up and just go around the shoulder. So that would be your extension. Okay? So let's do glenohumeral testing, you're kind of combining your test for glenohumeral mobility, so shoulder joint mobility, at the same time you're testing for scapulothoracic stability. It's almost like a combination test. So if she's restricted and it doesn't matter whether I press on her arm, it doesn't make it any better, we're just going to go into straight mobilization techniques. If she is significantly better, we're going to go after a combination of, say, rotator cuff and scapulothoracic stability. That's usually going to clear out that pattern. So in her example, we found, let's say that her shoulder pain was right. We did not see any thoracic rotation restricted issues. All we saw was a shoulder flexion, TPD, tissue sensibility dysfunction. So operating off of that, we're going to think about what structures in the shoulder would prevent someone from going into overhead. They would largely be the muscles that activate to the antagonist of shoulder flexion. So that would be your lat for abduction, internal rotations, your subscap, your pecs that internally rotate, some of your anterior delt. Those are all structures that are going to pull you forward. So if I'm going to apply some soft tissue, I'm going to do it to the structures that I think are limiting your mobility, and then also to the structures that I think are irritating. So with that, let's lay your face up. This would be an example of how we would do the ART piece of this. This would be the soft tissue treatment. The principle behind ART is nothing fancier than shorten the tissue, pin it when it's shortened, and then lengthen the tissue. So this concept would be my bicep. If I do this with my arm, I don't feel a stretch in my arm at all. But if I shorten this muscle, I pin it, and then I go to straighten it, I already feel a stretch at that point, and my elbow's not even fully extended. So in tissues like the bicep, the hip flexor, quads, etc., that you might not be able to get a good passive stretch on, sometimes we have to do this assisted style stretching that can help get that to go away. I always describe it to patients that if I tied a rope to the wall, and I keep tugging on this rope, the rope's going to start to fray where it ties to the wall. It's not going to fray in the middle. If I put a stretch on that rope and I pull really hard, most of that force is not going to be in the middle of the rope, it's going to be at the ends. And so this type of technique allows us to change what the ends of the rope are. So that same example, if I pull on that rope, but then I have someone else grab onto it right here, well now my focal point is that contact and this contact, it's no longer that contact and that wall. So we can focally remove restrictions within tissue in that fashion. So we were talking about, say, for subscap. So your subscapularis sits on the end part of your shoulder blade, wraps around the front of your shoulder, and then it's all over your shoulder. In order to stretch that, you use a flexion, external rotation, while working the subscap. So on Teresa, because of rotation, I have to come focusing her on press down. This is your shoulder blade. I'm going to come in and set down on the tissue like that. So that muscle sits right like this here. We're going to come in and sit down like that. And she's going to put her arms. I'm going to bring this into opposing motion. So she's going to go into flexion, external rotation. I'm going to feel stretching in my arm. She's going to feel stretch there too. We're going to hold that for as long as it takes to feel that tissue change a little bit, and then back off. One thing you always want to make sure is that you're only getting your end range of motion from the areas that you want. So for example, I will always tell a patient, Teresa, if you feel discomfort under my thumb, that's totally normal. Just let me know if it's too much. If you feel discomfort somewhere else in your shoulder, that's not what we're trying to achieve. Please let me know because I'm going to back off. If I'm doing that and I'm pinching on the inside of the shoulder and she's feeling a lot of impingement right underneath, like say her AC joint, that's a problem. I'm just going to irritate her shoulder if I try to grind through that. It should really only be your contact point that's giving them any type of discomfort. Make sense? So that would be what we call like a singular move. One single tissue that you shorten and then lengthen. A more complex move would be using two different tissues that need to be able to move opposing one another, that can sometimes lose the ability to move in them. And so an example in the shoulder here would be her pec minor and her anterior delt. So your anterior delt kind of wraps the front part of your shoulder, and then you have your pec minor that comes off of the chest and inserts on the anterior part of the shoulder. When you're trying to separate two tissues, you have to isolate out what's different between them. So a lot of tissues can have common movements, but there's always going to be some separating movements. So I'm sure you've all experienced this. If you're doing a push-up or a chest press of some sort, you're probably firing your pec and you're firing your delt. So straight extension is not really a separating factor. But because of the location of your delt, external rotation, that function is only going to lengthen your pec minor, but it's not necessarily going to lengthen your anterior delt. So we can use that as a separating factor. So if I'm palpating your shoulder for movement and I'm going into external rotation, I should feel just her pec minor move when I move her into external rotation. I shouldn't feel like the delt slide with it. If those are moving in conjunction, then we want to try to separate them essentially. So in that scenario, we can start with your hand in a relatively neutral position. I have to come underneath the pec major to go to where that pec minor is. And then my top hand will go where the anterior part of the delt is. And I'm going to create a motion like this, where I'm pushing the pec, I'm going to push the pec with the motion, and I'm going to hold the delt back. Does that make sense? So when she turns like this, I want the pec minor moving, and I want to separate the delt and hold it back, and not allow it to move, so you can create isolated motion between those. So my bottom thumb, top thumb, press the pec down towards the shoulder, and the top thumb will hold it back. Similar concept with your delt and the biceps tendon. So your delt moves obviously over the shoulder, your biceps tendon moves to the elbow. So when I move the elbow back and forth, flexion extension, I should see the biceps tendon gliding under the deltoid. If that's not happening, you start to go there. I would have my hand on my deltoid pressing back this way, my bottom hand on the biceps tendon going the other way. No fancy than that. Like people that came up with ART, we try to sell you on a concept that is this novel, amazing, patented, trademark, blah, blah, blah. It's know your anatomy, shorten tissues, create pressure, lengthen them under your pressure. Then also know your functional movements. Know how to separate those things out. Whether or not the organization ART taught you that specific move, or you were just smart enough to know the difference between how a delt fires and how a pec minor fires, you could probably put these pieces together on your own. So we're going to break up and talk about, or have you guys try some of these things, and then we can kind of circle back up if you guys have any questions. One big take home I would say that if you guys could have from today is not just the actual information we're talking about, but I've tried to reinforce this idea that as you guys move on in your careers, there's going to be this contention to align with one single approach. People are going to want to, you're only going to do ART, and ART is the only way to do it, or dry needling is the only way to do it. You have a lot of scenarios where people are going to try to put that on. I would say that should always be a red flag. If somebody's telling you my way is the only way and any other way is the wrong way, that's usually not somebody you might want to listen to too much. There is so much to be learned from other types of providers, other clinicians, other techniques. Build a tool chest. Have as many tools in that tool chest as you have, because you may have a patient that doesn't respond well to one technique, but really responds to another. So just highly encourage you guys to not get singular in a lane and get evangelist about one type of approach. Be open to learning all things and learning from people that come from different backgrounds and different techniques. So what we're going to do is maybe take half the group and we can go against the wall over there and half the group against the wall over there. We're going to have you do the thoracic rotation. We'll demonstrate that one more time. So we'll have one person who's going to be the clinician and then the other person who's going to be the patient. The patient's going to sit back all the way to their heels. They're going to take one elbow and put it on the table down in front of them. Other arm going to go behind their back. And they're going to try to turn the shoulder and open towards the ceiling. If they can't go to 50 degrees, you're going to try to press them a little bit farther and see what you can find. Okay, that's the first one.
Second one is going to be, we don't have tables for everybody, so it's going to be a little bit challenging to do any type of prone flexion. I'm just going to do it standing. I'm just going to go into the hinge. You're going to try to raise your arm. I'm trying to keep my elbow straight. Go back to the point where I'm at least in the plane of my ear. If I can't do that, something's going to come in and try to raise me higher. If that difference is more than 10 degrees, we would call that stability motor control. If that difference is less than 10 degrees and there's a restriction, we would call it tissue extensibility or tightness point. Does that make sense? Questions on anything? All right, we'll split up. You want to go that way, I'll go this way. Okay.
That's worse. That's definitely worse. Pretty limited there.
Okay, so that would be